હવે એ પ્રેક્ટિસ મોડ ચાલુ થઈ ગયું છે. ઓકે, જેને આવવું હોય આવે.
Dr. Madan Kapoor ji, welcome.
ભાઈ મારી વાત સુનો. આપને તમે મારા ઘરની તો રજા લઈ લો, ઠીક છે? તો 10 દિવાળે આવશે ને દિવાળે થઈ જશે. રજા લઈ લો, વાંધો નથી ભાઈ.
Hello, Mustafa, you have to make me co-host, Mustafa. I cannot share my screen. You are mute.
Done. Okay, screen is good now. Once Manal, she comes in and she will introduce Professor Ramzi Ajjan. Both the chairperson, they know, correct? They have to join immediately after this, or maybe during their board.
Yes, let just Insia come. She will call them if they are not joined. I will message Insia to join.
તારો તું ઘરે છે તે તારો બરાબર છે કનેક્શન ને ઇન્ટરનેટ નો?
હા, બરાબર છે.
હા. ઓકે. Exactly at 10 I'll start. It means 5 o'clock.
Okay.
We have like still 20 minutes.
Better 5 minutes before Mustafa if possible, no?
Okay.
So people can see what is going on this symposium. They can read about the symposium.
I think Dr. Madan Kapoor is here.
Yes, he has joined.
Yeah, it's here. Yes, tell me.
No, I'm just, everything is okay?
So far, so good. I just came to join. That's all.
Yeah, okay.
Nothing yeah. I'm not chairing, neither I'm speaking today.
You'll be, but you are chairing the session, right?
Tomorrow.
Okay.
Tomorrow.
So, Sabha, you sent the panelist link for today's speaker, right? To all the speakers.
Yeah, all gone. Again, 3-4 times, or maybe they received 5 emails up till now.
Okay.
Ms. Manal,
Yes,
can you check your camera and sound? I think it's okay.
yeah, just a moment. If you don't mind, I'm just closing some apps.
Good afternoon. Can you hear me?
Yes, Dr.
Yes.
Ramzi, we can hear you very well.
Super.
Yes.
That's great.
Yes, Professor Ramzi. I'll have the pleasure and opportunity to introduce you into this webinar.
Oh, so you're going to do the introduction. I'll wait for you. Yeah.
Dr. Ramzi, can you make sure you can share your screen?
Yes, let's try that.
Yeah.
You cannot start share while the other participant is sharing.
Okay.
So somebody else is sharing.
Okay, I'll do one thing. I'll just do some settings. Okay, now I think you should be able to.
This will stop other screen sharing. Do you want to continue?
Yes, you can continue. Yeah.
Okay, and here we go. Can you see that?
Yes, sir, very well.
Super duper. That's great.
Yeah.
Do you want me to stop sharing this then?
Yeah, you can stop sharing now. And because we're going to start exactly because we have like more than 1,500 people already waiting to log in.
Fantastic.
So exactly, let's say next 9 minutes, I'll start the webinar and people will start logging in. So Ms. Manal will introduce you exactly after 9 minutes and then you can present.
Very good. Thank you very much. That's great.
You're welcome, Doctor. Ms. Manal, are you ready?
Yeah, question for you, if you don't mind. Will there be any Q&A after the session, or once the talk is done, we close? Because because I just got notified that I will be moderating this session.
Yeah, but I mean, whatever the time permits, Ms. Manal, I mean, 45 minutes we have. So if you can manage in this time, you will be able to see all the Q&A.
Okay. Okay.
All
So
right, so
I'll be moderating the questions as well.
yeah.
Okay.
So I will start the webinar, okay, now. So
Yeah, but
three,
just to check if Professor Ramzi is back.
I am here. I'm here.
okay.
Okay.
Okay, so I'm starting it. Good luck. So here I'm starting it. Start it. You can start, Ms. Manal.
Okay, thank you. Good evening. My name is Manal, Regional Manager for Medical and Scientific Affairs at Abu Diabetes Care. Thank you very much for joining this session at the 8th Amiri Diabetes webinar. I'm very pleased to welcome our speaker, Professor Ramzi Ajjan, joining us all the way from Leeds, UK, and who will be presenting on addressing the unmet need role of sensor-based technology in managing type 2 diabetes. Professor Ramzi Ajjan is a professor of metabolic medicine at the University of Leeds and Leeds Teaching Hospital Trust UK. He runs a program of clinical and translational research studies aiming to improve outcome in patients with type 1 and type 2 diabetes. His research and clinical practice are focused on optimizing glycemic control in diabetes and reducing thrombosis risk in this population. Thank you very much, Professor Ramzi, for joining.
Well, thank you very much, Manal, for that lovely introduction. And hello, everybody, and salam alaikum. And it's nice to be with you, although I can't see you. Hopefully not for long, and things will change. So let me try to share the screen. Just see whether. Hopefully you can see the slides, and if you can't, then just let me know. So I really
See the
agonized.
slides are seen very well, Dr. Ramzi, just for information.
Super, great. So I did agonize over how to make the presentation here, but it's going to be sort of a two-stage. I'm going to discuss with you the drawbacks that we have at the moment when we are monitoring glucose. And then the second phase is going to be about how can we make this better. So this is my disclosure slide. And one thing that I wanted to say that at the end, we'll have plenty of time for discussions, because I really, really want to know your views and what are your opinion about this presentation. What should we do long term? So when it comes to HbA1c and glycemic management, anybody who deals with diabetes knows about HbA1c. We love it. We've been using it for decades. It correlates well with average glucose levels at a population level, and I stress at a population level. It predicts future complications, so it's a good risk marker. It is very easy to measure and understand, and it helps with target setting, because we can tell our patients, you know, your HbA1c is too high, is 9%, we want it to be 7%, or if you're using millimole per mole, it's above 75, we want it closer to 50, and so on. However, there's always a however. When it comes to glucose levels and A1C, look at this table, if you like. If your HbA1c is 7%, which is the third one from the bottom, from top, sorry. If your HbA1c is 7%, which is around 53 millimole per mole, your mean glucose is 8.6 millimole per liter. But look at the range on the right. It can be 6.8 to 10.2. Now, when we say HbA1c 7%, that's good control. Look at the one underneath it. HbA1c 8%, this is not good control. The mean glucose is 10.2, but please look at the range, 8.2 to 12.1. There's a massive overlap between the two. So what HbA1c is giving you is an average marker of glucose control. Doesn't necessarily always reflect how much glucose you've got in the cells that are affected by diabetes complications. And of course, we know that it is not always reliable when it comes to problems with hemoglobin, in anemia, in uremia, and even in ethnicity may have an effect on the accuracy of HbA1c. And from my point of view, it doesn't give you any information on hypoglycemia and glucose variability when we know that these two glycemic markers are associated with adverse outcome. I'm going to talk about that in a bit more detail. So when you think about HbA1c, let's just take a step back and think about it. What is it? What does it measure? So it measures average glucose control, of course, relies on the glucose uptake by the red blood cells, so the activity of GLUT1, and it also relies on how long the red cells are living. So if you have an average glucose, let's say around 8.5 millimole per liter, and your red blood cell turnover is average, your HbA1c is going to be around 7%. However, if you have low red blood cell turnover, so the cells are living for longer, for the same glucose exposure, your HbA1c is going to be higher. Now, conversely, if you have a red blood cell turnover that is very quick, so the red cells are living for much shorter time, then what you have is a lower HbA1c for the same amount of average glucose. And the problem that you've got that in this scenario, when the red cells are living for longer, you can overtreat and cause hypoglycemia. Whereas here, you think that A1c is very good, but actually is not. You can undertreat, and that increases the risk of complications because the cells in the kidneys, in the heart, in the eye are exposed to much higher glucose levels than you think. And let me just demonstrate that with a case that I saw last year. So this is a GP letter, general practitioner, said, could you please see this 42-year-old lady recently diagnosed with diabetes? Now, there's something odd. She's completely asymptomatic and her fasting glucose is actually very good. It's only 5.3 millimole per liter. So you look at her HbA1c in January 2020 was 46 millimole per mole or 6.3%. The repeat in June was clearly in the diabetes range. So the 46 not in the diabetes range yet, impaired glucose tolerance, but in June 2020 is 51 millimole per mole. So it has gone up to around, what would that be? So that would be 6.8%. Now, because her fasting glucose was normal, I thought, oh, let's check her full blood count in ferritin. And guess what? She had iron deficiency anemia. And diabetes was simply cured by giving her some iron therapy. The HbA1c in November 2020 was 41 millimole per mole. So you can see we cured diabetes by giving iron. Of course, we didn't because this lady never had diabetes. The A1C was misleading. So the take-home message is that HbA1c is useful, but can have its drawbacks. So let me just complicate life for you a little bit more. Now, studies have shown that the relationship between HbA1c and complications is actually not a straight line, but a U-shaped curve. I would like you to concentrate on the left hand of the slide. So if you look at the left hand, these are people, type 2 diabetes patients, where HbA1c was correlated with mortality. And these are, on the left-hand side, these are people who are not on insulin, they are on oral agents. And look at the numbers, rather big, almost 28,000 patients. And what you can see that if they have an HbA1c between 7 to 8%, their mortality is low. As HbA1c goes up, mortality increases. But surprisingly, when HbA1c is below 7, the mortality increases as well. Now look on the right hand of the slide. You look at people on insulin, still type 2s, but they're on insulin treatment, 20,000 of them, and you can see that safe window of HbA1c is more narrow. What does this suggest? It suggests that if you go very low with HbA1c, in some people, I'm not saying everybody, in some people, it can be detrimental. And the thing that makes me think about it, what can it be detrimental if it is too low? It must be hypoglycemia. Now, one thing I need to warn you about, that this study was criticized because they said a lot of people in the low HbA1c had comorbidities like renal failure, for instance, where we know HbA1c is lower, which I completely agree with, but still it makes you think that lower is not always better. And by the way, this has been shown more than once, so it's not only once. And actually, it was shown much earlier in surgical patients. So I would like you to concentrate on the yellow line, because the yellow line is the diabetes patient undergoing surgery. The pink line is the non-diabetes group, and the blue line is all the patients. So if you focus on the yellow line, what you can see is a very similar pattern. What this shows you here is all-cause 30-day morbidity following a surgical intervention. Again, it's a U-shaped curve. So if the HbA1c is between 6.1 to 7.1, they do well. Above it, they don't do well. And below it, again, they don't do as well. So lower, again, is not always better. Let's move on a little bit from HbA1c to glucose. Remember what I said earlier? I said lower HbA1c not being good could be due to hypoglycemia. So let's take this study. This is a study on myocardial infarction patient, and this is in hospital mortality. The solid line is people without diabetes. The dotted line is people with diabetes, and the dashed line is all the patients. So please focus on the solid line, no diabetes, and the diabetes, the dotted line. So this is what you've got here is in-hospital mortality according to the mean blood glucose. We're not talking HbA1c here. And what you see is something really striking, because if you have a mean blood glucose in the non-diabetes group around 170 to 180 milligram per deciliter or 10 millimole per liter, you get a 5-fold increase in hospital mortality. But in the diabetes group, you need to have a much higher blood glucose to have that 5-fold increase, around 250, which is around 14 millimole per liter. But look at the hypoglycemia. It's the other way around with hypoglycemia. So it appears that people with diabetes can tolerate the high sugar better, but when it comes to hypoglycemia, they do not do well. They do not tolerate the hypoglycemia as well. And that's really very important information. And look at when this was published, 16 years ago. So since then, we've known that hypoglycemia does increase cardiovascular risk. Now, of course, you do not believe anything until you do it yourself. That's what I usually say. And actually, we were lucky enough to do a study on ambulance call out for hypoglycemia. So this was hypoglycemia severe enough for the ambulance services to be called out. And what we found, we looked at their mortality following the hypoglycemic event. And what we found was this. So within 12 months of the severe hypoglycemia that requires ambulance call out, the death rate was 15%. And this is after excluding people above the age of 75, because we wanted to exclude them because we thought, you don't want to have frailty as the cause of mortality. Now, on the right, you can see the death in type 2 diabetes patients following MI in our region, very similar within a year. So if you have a severe hypoglycemia that requires an ambulance service call out, your risk of death is very similar to following myocardial infarction. If anything, it is slightly higher. And this was sort of type 2 diabetes patients. If I include the ones who are above the age of 75, the death was 24%. Now, what we've done after that, we have tried to do an interventional study to see whether we can modify this risk. And when I set up the study, I thought we will have nothing. We can't modify it, but I thought there's a study that is worth taking or worth doing. But I was completely wrong. So what we had type 1 and type 2 diabetes patients. The numbers are not that huge. We had around 320 patients. But you can see in the intervention, which was essentially a nursed based education about hypoglycemia. In the intervention group, which is the green line, there was less mortality than the other two groups where there was no intervention. And actually, this was driven by a reduction in mortality in the type 2 diabetes patients. And this paper has just been published a few weeks ago. Now, the other thing to remember, in addition to adverse outcome, hypoglycemia is very costly. So if you look at the cost of hypoglycemia requiring ambulance services intervention, the gray columns is the type 1, the blue columns is the type 2. You can see the cost is quite high, Germany, Italy, Spain, and the UK. And invariably, the cost is higher in the type 2 diabetes group because this is a group that ends up needing admission more than the type 1 diabetes. So it is quite costly. So we talked about hyperglycemia not being good, we know that. We talked about hypoglycemia being problematic as well. There's a third thing that can cause problems in diabetes, which is this, is glycemic variability. Now, glycemic variability is gaining more and more importance. People are getting more excited about glycemic variability. There's a large number of measures by which you can assess glycemic variability. In this particular study, they used coefficient of variation, which is something that everybody relates to. So what they've done, they looked at two things. They looked at the length of hospital admission. So this was a study in inpatients. So they looked at length of hospital admission and mortality. And they divided the patients into good glucose control, glucose between 90 to 180 milligram per deciliter, or 5 to 10 millimole per liter, and poor diabetes control, glucose above 180 milligram per deciliter or more than 10 millimole per liter. So focusing on the good control, what you have here on the left is the length of hospital stay, and on the right is mortality. The white columns is low glucose variability. The gray column is midway, and the black column is high glucose variability. And as you can see, as the glucose variability increases, the length of hospital stay increases, but more worryingly, mortality increases. And this is people with good diabetes control, remember. What about the ones with poor diabetes control? Very similar pattern. If anything, it is more obvious that increase in length of hospital stay and the increase in mortality in this group. So to conclude so far, A1C is generally useful in the diagnosis and management of diabetes at a population level. Remember what I said before, population level, but in some patients, it can be misleading. The relationship between A1C and clinical outcome takes a U-shaped curve, so lower is not always better. And finally, HbA1c fails to assess glycemic markers associated with adverse outcome, and that's hypoglycemia and glycemic variability, which are quite important. So therefore, I've said quite a few years ago that HbA1c on its own can be inadequate for the assessment of glycemia. I'm not saying forget about it. What I'm saying, it's not enough on its own.
Yes,
and in 2014, I proposed that we need to have this concept of the triangle of diabetes care, where we lower the glucose levels, but we avoid hypoglycemia. We try to limit glucose variability in order to optimize glycemic control, to make it perfect and improve clinical outcome. And guess what? I was not alone in my thinking, and actually my colleagues made this concept, even sort of developed this concept, if you like, to something far more substantial. And that brings me to this, the target range or time in range. So what they said, we want the diabetes patients to spend more than 70% of their time in target, defined as 3.9 to 10 millimole per liter, while spending less than 4% in hypoglycemia and they divided into 2 levels, hypoglycemia less than 3.9 and less than 3, and spend the rest in hyperglycemia. So we've got very clear-cut targets, but of course, this kind of targets you can't achieve without having continuous glucose monitoring, because you need a lot of glycemic data to know what your target range is. And this is why this at the moment is used mainly in type 1 diabetes, but I do not think personally that we should restrict it to type 1 diabetes. The other thing that I wanted to point out in relation to hypoglycemia, these guidelines say that if you have people at high risk of cardiovascular disease, high risk of myocardial infarction or stroke, the hypoglycemic target should be less than 1% rather than less than 4%, because we know that that population doesn't do well with hypoglycemia. So this was the first part of my talk. Let's move on to the second part. To have good glycemic control, you need that time in range, you need your hypoglycemia, you need your glucose variability. But for that, you need continuous glucose monitoring. And really, continuous glucose monitoring has been limited more or less to type 1 diabetes. So what about the type 2 diabetes population? Should we be using CGM in type 2? If the first question is, does it work? Now, if you look at a really, so this is a study, 14 years ago, and I think it's a very important study, and to my mind is not quoted enough. So this study asks a very simple question. Do people...
I would request, please, somebody to unmute the mic, please. Only Dr. Ramzi has to keep his mic on. There is a lot of disturbance. Please, somebody from the panel, please unmute the mic.
Right. So please unmute the mic. Right. So just looking at this particular study, they asked patients with type 2 diabetes to say how many hypos they are getting and what time of the day. And this was their response. This was their self-reported hypoglycemia. And it peaks, as you can see, around midday. And then they did a CGM, short CGM for 3 days to see whether that corresponds to what patients think. And there were 2 surprises. One, the number of hypoglycemic events was much higher than the self-reported hypoglycemia. And 2, they were occurring at night that people, the patients did not even know about. So I think this study shows you that hypoglycemia is massively underreported, and I think it's a very important study. And this is one of our studies where we looked at hypoglycemic exposure in a mixture of type 1 and type 2 diabetes patients on insulin treatment. So all these patients were on insulin treatment. And this is what we've got. It was 105 patients, good numbers, and a long CGM. We went for 3 months CGM. And this is what it showed, that they spend 1.2 hours a day in hypoglycemia. It's far longer than I anticipated. Some people were spending 4 hours. Now, of course, the type 1 were spending more time in hypoglycemia than the type 2s, but the type 2s were spending significant time in hypoglycemia. Now, one thing that people tell me all the time that, yeah, but hypoglycemia in type 2 diabetes only occurs with insulin therapy. I'm not so sure about that, because when it comes to our ambulance data, the study that we published 6 years ago and the study that we published 6 weeks ago, there was one consistent finding. People with type 2 diabetes, not all of them were on insulin. Up to a third were not treated with insulin. They were treated with sulfonylurea, and they still required ambulance call out for hypoglycemia. We were conducting this study on myocardial infarction, people admitted to hospital with myocardial infarction, type 2 diabetes patients on sulfonylurea or insulin. And this is one of the patients who got admitted. And if you want to see the number of hypoglycemic dots, so each dot represents hypoglycemia. This patient was constantly in hypoglycemia and was not on insulin, was treated with a sulfonylurea. And quite frankly, I initially thought that there is something wrong with the sensor, and I asked to have a SNBG, proper capillary glucose, and that confirmed that the patient wasn't hypoglycemia. The capillary glucose was 2.2. I still remember it. So I think it's very important to exclude hypoglycemia even in people who are not on insulin. One thing that was really interesting about this patient, of course, the sulfonylurea was modified. He was started on a different treatment. And he said, when you change my treatment, doctor, I started to think more clearly. And of course, this patient couldn't think properly because he was having hypoglycemia all the time. So when it comes to CGM or professional CGM, so the blinded CGM is often called professional CGM in type 2 diabetes. We're talking about traditional ones here. We're not talking about flash CGM. You can see that overall, the studies show that actually the CGM improves diabetes control, improves A1C in people with type 2 diabetes, but the number of studies is relatively small, right? But still, it shows a positive effect. What about flash continuous glucose monitoring in type 2 diabetes? What do they show? So we've got the REPLACE study, good numbers, 224 patients, all of them were on insulin therapy. So this is intensive insulin therapy, 4 injections a day, or on pump therapy. And this is the drop in A1C. The flash CGM is the blue column. The orange column is the control, and you have the baseline and final. And as you can see, there's a small drop in HbA1c in both study arms, but there was no difference between flash CGM and SNBG. However, it's a big however, there was a very significant change in hypoglycemia. And whatever hypo you look at, less than 70, less than 55 milligram per deciliter, less than 45, there was less hypo in the intervention group. And if you want to see it as a table, with a flash CGM, there was 43% less hypo at 70 milligram per deciliter if you take that as a cutoff, 53% less if you take the most significant hypo of 55 milligram per deciliter, and then 64% if you take the 2.5 as a cutoff. So the more severe the hypo you get, more benefit with a flash CGM. There's another study on intensively treated patient, the Yaron et al. Study. This actually showed an improvement in HbA1c with the use of flash CGM. This was a shorter study. REPLACE was 6 months. This was 2 months. But what it showed that in the control group, a drop of more than 0.5% in A1C occurred in 30%. But look at the intervention. Almost 70% had a drop of 0.5%. When it comes to a drop of more than 1%, 19% in the control group versus 39% with the flash glucose monitoring. So you get a significant drop in A1C with the flash glucose monitoring here. What about other groups of patients? I mean, we have done a study in acute coronary syndrome patients. This is not published yet. It was presented at the ESD, but the paper hasn't been published yet. We are submitting it in the next few weeks. But I'm going to show you the key data. So these were patients on insulin or sulfonylurea admitted with myocardial infarction, and they were randomized within 5 days of the myocardial infarction to either flash CGM or SNBG. What we had is this. So we had 72 in the control arm, and in the flash glucose monitoring 69. The mean age was 63. So if you look control active on the right, you've got the whole group. 63 was the mean age, diabetes duration 13 years. Now, 45% were on sulfonylurea and 55% were on insulin therapy. Of those on insulin therapy, the majority, 62%, were on mixed insulin, 23% basal insulin, and basal bolus 13%. And what we had is this. So when it comes to HbA1c, study beginning day 0 and day 90, both study arms, the flash CGM and SNBG, the HbA1c actually dropped significantly by 7 millimole per mole. But there was no difference between the two study arms. So we improved diabetes control. 7 millimole per mole is a significant drop. We improved diabetes control, but no difference between the groups. However, again, look at the hypoglycemia. So what we had at very early on with the second sensor, so this is day 16 to 30, this is only the second sensor, you can see almost an hour reduction in hypoglycemia with the intervention. And that occurred whether patients were on insulin or were on sulfonylurea at baseline. Now, of course, you say, well, was this sustained or did it just disappear? And actually, when we looked at 90 days, 76 to 90 days, if anything, that was far more exaggerated. So it was more than 1 hour, the drop. And people who were initially on sulfonylurea had a 2-hour drop in hypoglycemia. So a pretty significant reduction. So the Liberates trial shows that you can reduce HbA1c with a flash glucose monitoring with similar to SMBG, but with far less hypoglycemic exposure, which I think is very important in a vulnerable group like people with MI. So these are all the studies, put them together in one slide, the randomized control trial that is, when it comes to type 2 diabetes and flash CGM. The blue column is the control, the red column is the intervention, and then the dark area is how much HbA1c dropped by. So replace intensive insulin treatment for 6 months, both study arms, 3 millimole per mole reduction in HbA1c, right? In replace, one thing I didn't mention, people who were less than 65 years of age had more reduction in HbA1c with the flash glucose monitoring. So younger people did better. In the Yaron study, again, intensive insulin therapy, shorter study, only 2 months, smaller study, 101 patients. The control group, 3 millimole per mole reduction, but with a flash, 9 millimole per mole reduction. The WIDA study I didn't mention is a study that was conducted in Japan in non-insulin treated patients with type 2 diabetes. So these guys were not on insulin, smaller study, 100 individuals. At 6 months, there was a reduction in hypoglycemia more with the flash glucose monitoring compared with the controls, 5 millimole versus 2. And the last one is our Liberates trial, the one with people with MI, around half of them were on sulfonylurea, half on insulin. Both study arms had a 7 millimole per mole reduction in HbA1c, but you've got to remember that in Replace and Liberates, there was a very significant reduction in hypoglycemia. And we know that hypoglycemia is not good in people who had myocardial infarction. What about real world data? So these were randomized controlled trials. Very briefly, real world data, what they usually show, so they're comparing baseline with a change after a period of time. So there's a study from Austria, France, and Germany that shows almost a 10 millimole per mole reduction in A1C after you start flash CGM. The other thing that I wanted to point out is the non-glycemic effects, right? We always focus on glycemia and tend to forget about something called PROMs, or patient-related outcome measures. And this is something that is becoming very, very topical in terms of convenience, anxiety, how do the patient feel with a particular intervention? And actually with flash CGM, a number of studies have shown positive effects on PROMs in type 2 diabetes. There's a reduction in anxiety and increase in patient convenience. The other thing that I noticed from clinical practice, that the flash CGM facilitates a more meaningful discussion between patients and healthcare professionals, because you can tell them, look, this is what's happening. After you have your breakfast, you have this big peak. What are you having for breakfast? You can have that discussion. Or you're having that hypo during the night. What's happening then? And I think it's really very important and very fruitful discussion. The last bit I wanted to mention is affordability. Now, the flash CGM, of course, it's more expensive than SMBG. So in a healthcare system like the UK, which is free, we can't advocate that all type 2 diabetes patients should use sensor technology, at least for now. when the prices, maybe in the future prices drop and we'll be able to, but for now we can't, so we can't recommend it. However, there are groups of type 2 diabetes individuals who would benefit from such a technology supported by clinical studies or clinical experience. And this is what I would like to sort of show you here and judge whether you agree or disagree with me with this approach, because I would really like to hear your views. So the type 2 groups, in my view, that may benefit from Flash CGM include MDI treated, so multiple daily injections of insulin, type 2 diabetes individuals supported by Replace and Yaron studies. So at the very worst, you're not improving A1C, but you're reducing hypoglycemia, or in some people, you reduce A1C or you reduce both. So I think we've got enough evidence for that. Post-MI, that's our Liberate trial, you're reducing hypoglycemia. Of course, this is only a single study. Individuals sustaining severe hypoglycemia, you know, those ambulance call out for hypoglycemia or hypoglycemia requiring third-party intervention, we have a study in setup to investigate this in more detail. Cancer patients undergoing active therapy, again, we have a study in setup for that. Before elective surgery, because we know that if your HbA1c is high before surgery, people don't do well. So if we want a quick improvement in glycemia, maybe that would be an option, but we don't have the evidence. Nursing home resident. So there are UK observational studies ongoing analyzing the cost effectiveness of this approach, because if the nurse doesn't have to go out all the time to check the glucose of these patients and can access it remotely, that can be very cost effective. People who can't perform SMBG, people who've got severe rheumatoid arthritis, people with Parkinson's disease, I think you've got good clinical ground to say Flash CGM would be an option. And then intermittent use. So when you're escalating therapy, you want to know whether the new therapy worked, because if you don't do this, it'll take you ages, it'll take you 3 to 6 months with the repeat A1C to know whether the new therapy worked. Stable insulin therapies, just to make sure intermittently that they're not getting hypoglycemia. And of course, if you have a disconnect between A1C and glucose levels. And of course, you can argue, is there some other groups who may benefit? I would love to hear from you. So to conclude, general conclusions, the limited studies on using glucose sensor technology in type 2 diabetes patients show a favorable effect in glycemia. So it's a reduction in A1C and or hypoglycemia with, don't forget this please, superior patient satisfaction. We want our patients to feel better. So it's not all about what we want, but what the patients want. Use of glucose sensor technology in all type 2 diabetes patients is not feasible, at least in the UK, because there will be cost implications. So we need to start with subgroups. MDI treated patients in the UK, that's roughly half the type 1, so not huge numbers. Possibly post-myocardial infarction, the Liberate trial, clinically relevant groups that we discussed earlier. And of course, intermittent use of the technology may be an option in some patients. But of course, we require more studies on glucose sensor use in type 2 diabetes patients. And I think we're just starting. So thank you very much for your attention, and I'm ready to take any questions or comments. Thank you very much.
Thank you very much, Professor Ramzy. I just want to ask the technical support, because I see people from the audience, they're raising their hands. But will you take the questions from the audience, or we ask them to type it in the Q&A box?
Manal, I can see a question already in the Q&A box. So there was a question about what's the best way to monitor glucose in people with anemia. So people who've got anemia and diabetes. I think this is an excellent question, because HbA1c can be completely misleading here. So if they have a hemolytic anemia, the A1C could be too low, and you get into this false sense of security that everything is fine when it's not. Iron deficiency anemia, as I showed you, the A1C can be high. So in these guys, you've got to rely on SMBG preferably CGM, and then do other tests like fructosamine, for instance, rather than doing HbA1c, which could be completely unreliable. So from my preference, if you can do CGM, that would be the best without any question. And if you can't, then fructosamine can to some extent replace HbA1c as an average marker of glycemia.
Thank you very much, Professor. I'll just like to ask all the audience to type their questions in the Q&A as per the technical support. While the audience type their questions, Professor Ramzy, quick question. When you mentioned the intermittent use of a sensor-based technology with the type 2 patients, the groups that you described that could potentially benefit, or we have evidence on that. How do you describe this intermittent use? Because, you know, with the challenges in availability, the cost, how do you give some guidance on the use in that sense?
So you will have some sort of general consensus. For instance, if you're escalating therapy, I think it would be really helpful to have CGM before and after escalating therapy, and then you can see that glucose levels fell, hypoglycemia was not induced. And then, you know, you do it every 3 months. It depends on the patient, obviously, but my view would be that you do that CGM every 2 to 3 months just to make sure that it stays as it is. People on insulin therapy, you want to make sure that they're not getting hypoglycemia. So you can do that CGM every 3 months or so, just to be absolutely sure that everything is fine. Now, I'm not saying that we forget about A1C. We do use A1C, but we use it as complementary. So we need more data, and this is how you'll be using the CGM intermittently. I hope that answers your question, Mana.
Yes, thank you very much, Professor. Still waiting for those who raised their hands to type in their questions. Also, another question that comes to mind while using with the type 2s, because, you know, we always get this inquiry that maybe they are not the more engaged in terms of technology. So also in terms from your experience, how do you see that, how we're able to address also knowing that maybe if they have proper understanding of this technology, their quality of life and the problems could be improved. So how,
that's a brilliant question, actually, Manal, because this is when the healthcare professional and patient relationship become very important, because you need to know what your patient can take in. So for instance, when I start people on a flash glucose monitoring, it depends on the patient how much information I give them at one go. And what I try to do is to do things step by step, rather than giving them all the information at one go. Some people can take in more, some people can take in less. What you don't want to do, and this is important, you do not want to overwhelm the patient. You overwhelm the patient, you lose them. So I think it depends very much on the patient, and you need to know the patient for that, of how you do it. Now, when we've done our myocardial infarction study, these were older people, and I was worried about how they would cope with the technology, but they coped brilliantly, but we had to support them. Of course, we had to support them more than the young type 1, but they coped very, very well indeed. So it's going to be on a patient-to-patient basis how you deal with this, really.
Yeah, thank you very much, Professor. There's a question for an elderly patient undergoing chemotherapy. Do you advise taking the COVID-19 vaccine? And if yes, when should they take it?
Yeah, so I guess this is diabetes patients undergoing COVID. These patients these are vulnerable groups. And of course, I would advise having the vaccine, but you need to be very careful at what stage of the chemotherapy they are, because sometimes they can't mount a proper immune response. So this has to be done in coordination with the person managing their cancer. But if it is in remission, absolutely, yes, they should go for the vaccine.
Thank you very much, Professor Ramzy Ajjan. I think we're on time. Appreciate your talk, and appreciate also your presence with us at this evening's symposium.
Thank you very much. And thank you for the audience for listening to me.
Thank you very much, Professor. And thank you also for
Bye-bye.
the organizing committee and for also the invite to be on this, the 8th Amiri Diabetes webinar. Thank you very much.
Thank you.
Thank you.
Good evening, our dearest attendees, and welcome to the second day of the 8th Amiri Diabetes webinar. I would like to present the next speaker, Dr. Ahmed Al-Hashimi. Dr. Ahmed Al-Hashimi, he's a senior specialist in endocrine and metabolism, diabetes and metabolism at Al-Adan Hospital. He's a clinical tutor in Kuwait Institute for Medical Specialization and the Faculty of Medicine. Dr. Ahmed completed his training in internal medicine and endocrine and metabolism at the University of Toronto in Canada, and followed by 2 clinical fellowships and a master's degree in the field of medical education. So welcome, Dr. Ahmed, and the floor is yours.
Thank you very much, Dr. Awsan, for the introduction, and good evening all. And it's my pleasure to be here with you today to be talking to you about the management of diabetes in COVID patients as our first talk for today. So I'm going to start by sharing my slides. Just give me 1 second. And I'll select. All right, so I believe you can see my slides now.
Yes, Doctor, we can see very well. Everything is good, perfect.
Excellent, perfect. Thank you very much. Thank you. So today I'll be talking to you about the management of diabetes in COVID in patients with COVID-19. So as you know, COVID-19 is a very new disease. We don't have that much data on how to manage diabetes in patients with COVID-19. But what we will do is we'll go over, we'll do a little bit of an overview of infections in general in patients with diabetes and how diabetes can have effects on by increasing the risk of certain infections, and how diabetes control can also have an important role in managing patients who are ill with severe infections. So this is going to be a somewhat light talk. It might finish early, so ask questions as much as you like, because I wanted to make sure that we have extra time for questions today. But what I will do is I will try to cover the basics and then give you a chance to ask questions so we can explore the areas that you would be more interested in. So before we go any further, I want to remind you that the patients with diabetes are at increased risk of infections. So in this very nice big study, it's a database study. So what they did is they took thousands of patients with diabetes and then multiple thousands of patients without diabetes, and they compared them for the risk of certain kinds of infections based on, it's a database study. So they looked at billing data in Canada. And what they found is that there is an increase in the risk of diabetes. So I'll point you to where the most relevant information is. So this is the adjusted odds ratio for patients with diabetes for different kinds of infections. And what you can see here is, so in this column here, there is an increase in the risk of any infections by about 20%, head and neck, 13%, and then, like different kinds of infections, especially skin and soft tissue infections are increased in diabetes. And you see this clinically. You see a lot of patients with diabetes, when their diabetes control is poor, they start developing those, small abscesses under the skin. They might get a bit of a skin infection that sometimes is treated locally with fusidine cream or something like that. But that can sometimes develop into something bigger. and worse. So it's very important to remind our patients with diabetes that they are at increased risk of infection in general. Now, we don't have data supporting the hypothesis that diabetes increases the risk of catching COVID-19. We don't think that diabetes puts you at increased risk of catching COVID-19, but it does put you at risk of developing other kinds of infections, mainly fungal and bacterial infections. We know this from before. So like putting COVID-19 aside, patients with diabetes are at increased risk of developing infections in general, and skin infections especially. Urinary tract infections are also common in patients with diabetes, especially when the diabetes is poorly controlled, partly probably because of the glucose that goes into urine. And what happens is when glucose goes into urine, it has some effects on the lining, the integrity of the lining, and maybe also some effects. The glucose itself might have some effects on the defenses that we have in the genitourinary tract against bacterial infections, and this promotes bacterial overgrowth and the urinary tract infection, and then subsequent development of urinary tract infections. So I'll give you just a list of some other examples of infections we see in patients with diabetes. So you see things like onychomycosis, for example. So very common. A lot of patients will come complaining of that, and we treat it usually locally with creams and that sort of thing. But of course, as you're all well aware, this can be the beginning or a risk factor for developing something that's bigger. So if there's a fungal infection here, maybe it's just a fungal infection. It's not affecting them that much, except for the way it looks. But this can put them at risk of, for example, developing some bacterial overgrowth, subsequently maybe some sort of an infection under the skin that they don't feel very well because they've lost their sensation. And this can, unfortunately, in some patients, this can be how they end up with an amputation. So it's very important. Those things are very important. Patients with diabetes, that's why we always talk to them about foot care, right? Another common infection is Candida. So Candida can be in those areas where there is increased sweat or there is friction, that sort of thing. So anyone can get a fungal infection there, but it's more common in patients with diabetes. And then they can also get fungal infections in their mouth, like oropharyngeal candidiasis is also more common in patients with diabetes. So as you can see, a number of infections can be increased. Necrotizing fasciitis is a more severe infection that patients with diabetes can get. And again, I'll remind you, all of those infections are bacterial and fungal, not viral. But if someone gets a viral infection like COVID-19, they end up in hospital, they may be at increased risk of developing superimposed bacterial infections and fungal infections if they have poorly controlled diabetes. So even though diabetes itself doesn't increase the risk of COVID-19, it does increase the risk of other infections. And one of the things that patients with diabetes also experience is they have more colonization with more virulent kinds of bacteria, such as Staphylococcus aureus. So they have more Staphylococcus aureus on their skin, and so if they are colonized with Staphylococcus aureus when they get into hospital, they may end up developing a severe infection with a staph infection, for example, after having COVID-19. So this is something to keep in mind as well. And so necrotizing fasciitis is the big one. Another important one is malignant otitis externa. So in those patients, there is a severe infection of the earlobe, basically, so the outside part of the ears, and this can be life-threatening because it can be connected to deeper structures. It can invade into bone, that sort of thing. So that's very bad. And whenever we talk about diabetes and infections and bone, especially, and the face, the biggest thing we worry about is of course mucormycosis. So mucormycosis is a very scary fungal infection that is mostly in patients with diabetes or patients who are immunocompromised for other reasons. So this is very interesting, I think, infection is that it only affects people who are immunocompromised or they have diabetes. So it tells you that those patients with diabetes, there is definitely a component of immune deficiency. So there is an immune deficient aspect to diabetes, especially when diabetes is poorly controlled. So it does put patients at increased risk of all sorts of infections, like we just said. So whether it's a skin infection, it's a fungal infection, or something really severe like mucormycosis that can basically destroy someone's entire face. And the treatment is with antifungal and antifungal therapies like amphotericin B. They of course need to go to the ICU. They usually end up being intubated. They may need big debulking surgery, and the surgeons will have to go in and cut big chunks of their face, which is very scary. It's a very scary infection. So if we focus a little bit now on COVID-19 itself and diabetes and the link between the two. So I've got some information here from this very, very good review that was written and published in Nature Endocrine Review. And what they did here is they looked at the things that can happen in COVID-19 infections. So, and we know that patients with diabetes are more likely to develop severe COVID-19, right? We know that they are more likely to develop severe COVID-19. So they tried to look at like, what's the pathophysiology for COVID-19 or severe COVID-19 infections. And then they looked at what the pathophysiology for diabetes is. And they saw like, where are the areas where we can link the pathophysiology of diabetes to the pathophysiology of severe COVID-19? Is there something that happens in COVID-19 infections that we know is more common or worse in patients with diabetes? So this is what they came up with there. So this is the, so if we go from the top here, we got an infection with SARS-CoV-2. And then we, of course, everyone talks about the cytokine storm, right? So on the left here, we got the inflammatory cytokines. We got the toxic metabolites that are produced by those cells. So there is a big immune response after the viral infection. And this immune response is probably what causes severe COVID-19, right? And so there are all of those changes in the immune system. We have an increase in natural killer cells, cells in patients with COVID-19. And then here we have an increase in some cytokines like interleukin-6 and other cytokines. And so those are increased in patients with COVID-19. We have activation of the RAS system. So the renin-angiotensin-aldosterone system is activated in patients with COVID-19. There is an increase in the level of angiotensin 2 in those patients. And then finally, we have the hematological changes. So we've got an increase in fibrinogen and D-dimer levels go up significantly in patients with COVID-19, regardless of whether or not they have clots, because unfortunately, a lot of people think that D-dimer is an indicator of blood clots. It's not a specific indicator of blood clots. It's just that if you have a blood clot, it is unlikely to be negative, normal. So D-dimer normal. So D-dimer is sensitive, somewhat sensitive for deep venous thrombosis or venous clots. D-dimer is sensitive for venous clots, but it's not specific. So if you see a high D-dimer, it doesn't mean they have clots. They could be bleeding. They could be in DIC. They could be in many other, and just being in an inflammatory state will increase your D-dimer. So be careful about that. So just because D-dimer is high doesn't mean this patient has blood clots, and definitely does not mean that they should be given anticoagulant just because the D-dimer is high. So it's very, very important. Unfortunately, this has become a pitfall. A lot of physicians and also non-physicians have like somehow picked up this piece of information where, you check your D-dimer if you have an infection, and if it's high, you take aspirin. There is no scientific basis for doing that. In some patients, yes, they may need some anticoagulation if they do develop clots. And of course, we give everyone anticoagulation for prophylaxis if they end up in hospital and they're not walking. So we give them DVT prophylaxis, of course, and we know it's a prothrombotic state, this disease. But we don't give people medications without enough evidence, because there is always a risk, of course, right, with any medication, especially if you give it to a lot of people. So even if the risk of aspirin is not very high, if you start giving aspirin to everyone, some of them will develop complications. And if none of them benefits from it, then we've done the wrong thing, right? So we always do no harm. So I just wanted to remind you of that. So D-dimers do not mean clots and do not mean you should take aspirin or any other anticoagulant unless there is evidence of an actual clot. So moving on, so down the cascade here, we got the inflammatory cytokines will lead to lung fibrosis and acute lung damage, or ARDS, which is one of the biggest things that our patients present with. So you've got the X-ray with the white lungs, a typical picture, or the patchy ground glass appearance on X-ray, which we've seen a lot of course, during our course of managing patients with COVID-19. You got the hyperglycemia. So this hyperglycemia, again, this is just the pathophysiology of COVID-19. We're not talking about diabetes yet. So even without diabetes, COVID-19 will cause high blood sugar. And in fact, there's been several studies linking fasting blood sugar levels, or not fasting, I mean, random blood sugar levels for patients who come in. So if you check their plasma blood sugar on admission, the higher the blood sugar on admission is, the higher the risk of severe COVID-19 infection. So if they come into hospital not yet in a severe infection, and their blood sugar is high, their risk of having a severe infection subsequently while in hospital, or dying in hospital even, the risk is increased. This is based on a Chinese study, a big Chinese study that was early on, in fact, in the pandemic. So blood sugar hyperglycemia is a risk factor for severe COVID-19, even in people who do not have diabetes. And so now, what they're showing here is, if you look at those, the big bolts, right? Those signs. So what those things are like, those are the boxes that get worse in patients with diabetes. So diabetes will make each of those boxes worse. And as you can see, there are multiple places where diabetes can interfere with the pathophysiology of COVID-19 and make COVID-19 infections worse, which increases the risk of developing the cardiovascular events, the thrombotic events, the DIC, the blood clotting, and then eventually cardiovascular and all-cause mortality that can go up in those patients because of the effects of diabetes on all of those things. So insulin resistance, endothelial damage, all of those are worsened in patients with diabetes. So moving on, what they did here, though, is that, so the first slide we were looking at, we took COVID-19 pathophysiology and we tried to identify the places where diabetes can make things worse. And this slide, it's only about diabetes. So let's leave COVID-19 aside. We'll just look at COVID-19 in patients with diabetes specifically. And of course, this is how COVID-19 affects the diabetes. So there is an interplay, like the COVID-19 COVID-19 infection makes blood sugar go up and make the diabetes worse. And there's been some suggestion that COVID-19 cannot even induce diabetes. So someone who does not have diabetes may get a COVID-19 infection, and then subsequently they end up having diabetes long-term. So not just high blood sugar when they're critically ill, but they end up with diabetes afterwards. And there's been some hypotheses about why this happens. Some suggestions that there may be an immune response that is produced by the virus, and then this immune response damages the beta cells. So it's somewhat similar to how type 1 diabetes develops. But there is also clotting and infiltration into the pancreas. So it can damage the pancreas directly, which again lowers the patient's ability to produce insulin, and then puts them at risk of maybe in this case would be type 2 diabetes, because there is a relative reduction in insulin, but not absolute. So patients can develop diabetes as a result of COVID-19, and they can develop severe COVID-19 as a result of diabetes. So not to belabor the point here, but as you can see, there are a number of mechanisms by which COVID-19 can make blood sugar control worse. So there's dysregulation of glucose metabolism. There is worsening inflammation, and the inflammation itself can also make the blood sugar worse. And the blood sugar being worse can make the inflammation worse. So when you see a two-sided arrow here, that's a big problem. When you see something causing, like one pathophysiological pathway worsens another pathophysiological pathway, and this pathophysiological pathway worsens that one, this is what we call a vicious cycle, right? So a vicious cycle is when you have two things and each one of them is making the other worse. So vicious cycles are really bad, and we have a number of them here. This is not good, right? So the point here is, like patients with diabetes, regardless of whether it's type 1 or type 2, patients with diabetes, they don't do very well with COVID-19 infections, and that's to be expected because of all of those physiological changes. Now, we'll just talk a little bit about, if we think theoretically, now we don't have data saying that this medication is better in patients with diabetes during COVID infections than that other medication. like it hasn't been studied yet. There is only one trial, and I'll talk about it in a second. There was only one trial trying to investigate that, but it's not really a diabetes trial. In fact, it's a diabetes medication, but it's being used for something else. And this is a common theme, I think. Over the last 2 days, you've seen how SGLT2 inhibitors are being tested in patients without diabetes and with heart failure, for example, have already been approved, patients with renal disease, that sort of thing. So starting with DPP4 inhibitors, as you know, so this peptidyl peptide 4 inhibitors. So what they do, the pathophysiology of DPP4 for diabetes control. Now forget about COVID for a second. So how do they work for patients with diabetes? How do they lower the blood sugar? So they work on the incretin effect. So what that means is when you give someone a DPP4 inhibitor, you prevent the breakdown of GLP-1. GLP-1 is produced by the gut and is broken down by DPP4. When you inhibit DPP4, GLP-1 does not get broken down. So you get increased levels of GLP-1. Still, GLP-1 has a short half-life, so it doesn't stay for too long. And it still doesn't go very high, but it does modest increase in GLP-1 levels. And what this does is it basically improves the pancreatic function postprandially. So after someone eats food, their pancreas produces more insulin if they have more GLP-1. And so DPP4 inhibitors increase the endogenous GLP-1 levels in people. So that's how they work for diabetes. But there's been studies there's been interest in the DPP4 receptor in patients with MERS. So as you know, MERS is the Middle East respiratory syndrome. So it's also a coronavirus that is similar to COVID-19, but it was a different strain. And so there's been studies from before showing that some patients who have polymorphisms to DPP4, they may be at lower risk of catching MERS. So that's one thing. And then on the other hand, patients with bad MERS infections, their DPP4 levels in the blood are lowered. So there is some question about whether DPP4 as a receptor, if you have low numbers of DPP4 as a receptor, that's a good thing. But if you have high levels of DPP4 in the blood as a soluble molecule going around in the blood, that's a good thing. And this is what we get with DPP4 inhibitors. In fact, if you give someone a DPP4 inhibitor, you will see less receptor activity, which is the point, right? But when the DPP4 is floating around in the blood as a soluble molecule, it actually goes up in patients who get DPP4 inhibitors. So that's interesting. Of course, we also have some data saying that DPP4 inhibitors have some benefits in terms of inflammation, that sort of thing. So based on those hypothetical reasons, and also the effect of GLP-1, which we know GLP-1, and I'll show you in a minute, GLP-1 does have immune modulatory effects. We think that DPP4 inhibitors are actually a good option in patients with mild COVID-19 infections and diabetes. And similarly, GLP-1 receptor agonists in COVID-19, again. So we know, first of all, before we even talk about pathophysiology of GLP-1 receptor agonist directly against COVID-19, we know that GLP-1 receptor agonists are good at lowering patients' weight. They are good at protecting against cardiovascular disease, and they reduce the risk of progression of kidney disease in patients with diabetes. So based on that alone, and we know those are 3 important risk factors for severe COVID-19 infection. So if you have a patient with diabetes who's even not infected yet, I would always prefer switching them to GLP-1 receptor agonists if I can to get those benefits and hopefully reduce their risk if they happen to catch the COVID-19 infection. But in addition to that, in addition to all the benefits they get in general as patients, GLP-1 receptor agonists have been found to reduce markers of oxidative stress and in patients with type 1 diabetes. So actually, it's not GLP-1 receptor agonists. It's, in this case, it was the native GLP-1, the GLP-1 that's produced by the pancreas. So it was given as an infusion to patients with type 1 diabetes, and they found that this did reduce some inflammatory markers and some cell changes in plaques and that sort of thing. And it's also been found clinically, GLP-1 receptor agonists now have been found clinically to be beneficial in in some inflammatory conditions, chronic inflammatory conditions like non-alcoholic fatty liver disease, for example, or atherosclerosis, so that we know that they reduce the risk of cardiovascular events, specifically atherosclerotic cardiovascular events. And so based on that, we think that GLP-1 receptor agonists are good for patients with either mild COVID-19 infection or who have not developed COVID-19 infections, but are at risk of developing it. Then we've got SGLT2 inhibitors, as you know, again, very good data on reducing cardiovascular risk, especially heart failure, and also progression of kidney disease in patients with type 2 diabetes. Like I just said, those are risk factors for severe COVID infections. So if you want to prevent severe COVID infection, you want to protect patients' hearts and kidneys. So you should give them medications that protect hearts and kidneys, right? So we control their blood sugar and we give them medications that protect their heart and kidney. So that's why I choose things like GLP-1 receptor agonists and SGLT2 inhibitors. So this would be a good choice. But you have to remember that with SGLT2 inhibitors, in patients who are severely ill, there is a risk of DKA. That's also why we don't give SGLT2 inhibitors to patients with type 1 diabetes. Because some people might say, you know, like that SGLT2 inhibitors would be good for patients with type 1 diabetes. Why? Because the mechanism of action doesn't depend on the pancreas. In SGLT2 inhibitors, the action is in the kidney. And patients with type 1 diabetes, their pancreas doesn't work, but we can still give them an SGLT2 inhibitor, right? And we would be able to lower their blood sugar because the action is in the kidney, but the problem is they increase the risk of DKA. So that's why we don't give them to type 1 patients because of the risk of DKA. But in patients with type 2 diabetes who are very critically ill, who are with very severe COVID-19 infections, they are at risk of DKA. In fact, there has been one study that looked at all patients who had COVID-19 infection and presented with DKA, and they found that 70% of patients who presented with DKA due to a COVID-19 infection, 70% of them had type 2 diabetes. So it's just because it's so severe that it can induce DKA even in patients with type 2 diabetes who don't typically get DKA. Of course, the reason it was a higher proportion of patients with type 2 is because there is that type 2 diabetes is much more prevalent in the population. It doesn't mean that COVID-19 doesn't cause DKA in type 1. It's more likely to cause DKA in type 1, but if you look at those coming to hospital, they are more likely to be patients with type 2 because it's more common. Type 2 is more common. Okay, so when we talk about the anti-inflammatory benefits here, but be careful about DKA and volume depletion. So those patients with SGLT2 inhibitors, you know, SGLT2 inhibitors, they work by getting rid of glucose and salt and water through the kidney. And so they can become volume deplete if you're not careful. If they have a fever and they're not drinking very well, or they're throwing up, they have vomiting, they have diarrhea, that sort of thing. And you put them on an SGLT2 inhibitor, or you don't stop the SGLT2 inhibitor, you might make things worse. So you have to be careful with the SGLT2 inhibitors if they are sick.
Sorry, Dr. Ahmed, 5 minutes left. 5 minutes left.
5 minutes, yeah. Okay, all right. But there is one study, the DARE19 RC. It's an RCT. It's a randomized control trial on patients who are in hospital but not critically ill, and it's comparing dapagliflozin versus placebo. TZDs, better avoid. They can cause weight gain. They can cause edema. They can precipitate heart failure. So especially if they are sick, you shouldn't use them. And their use has been coming down significantly. I haven't seen a patient on TZDs in a long time. So TZDs in quote would be Actos. So if you have patients on Actos, they're at risk of COVID-19 infections, better avoid them. So based on this theoretical data, the authors of this study or this review, they suggested this guideline for which medications you should use, depending on how severe the infection is. So I'll leave it for you here. And finally, in the last 5 minutes I have, or 1 minute, I'll just use 1 minute and then open it up for questions if there are any important ones or urgent ones. The most important intervention, and if you look here, this is the cumulative. So this is day 0, enrolling patients in a trial, okay? This is placebo. So placebo, if you don't take this particular medication, your cumulative risk of developing a COVID-19 infection looks like this, okay? If you do take this medication, this magical medication, your cumulative risk of developing COVID-19 is like this. So like it's just like it goes up a little bit and then it's flat. And that is a very impressive result. And of course, I'm talking, of course, about vaccines. So this is the Pfizer vaccine as an example, but other vaccines, very similar results. So the most important intervention you can do for patients with diabetes, whether it's type 1 or type 2, is to make sure they go register for the vaccine and they actually go in and take the vaccine, and continue to be cautious not to get the infection before the vaccine kicks in. COVID-19 in Kuwait is still it's still very prevalent. We're still in our second or third or even first wave, if you want to call it a first wave, because we never really went down to zero. So it almost feels like one big wave. But in any case, this wave continues. This is last results. Here we've got 12 people who died. This is for me the most important number, is the percentage of positive swabs to total swabs. This number, as long as it is more than 5%, the wave is not under control, and it hasn't been under 5% in a very long time. So it's not under control. It's not going to come down tomorrow. Okay, it's still bad, unfortunately. And finally, so this is COVID-19 in Kuwait. So I'm just going to talk to you about diabetes in Kuwait. This is the last slide I have. This is an excellent study published by the group in Desman. And if you look at the age groups here, 1, 2, 3, 4, this is pre-diabetes prevalence and diabetes prevalence. And if you look at diabetes in people who are 60 years or older, prevalence of diabetes is 64.8%. So more people in Kuwait above 60, more people have diabetes than do not have diabetes. So if you flip a coin, you're more likely to have diabetes than, like, it's not even flipping a coin, having diabetes, it's more than that. So diabetes is extremely common in Kuwait. If you look at the group of people between 45 and 59, it is 40% of people have diabetes. So this is a very important topic for us here in Kuwait. We are in the middle of a pandemic. We are in the middle of a wave, and we have a population that has a lot of patients with diabetes. So I hope I was able to help a little bit illustrate why we care so much and how we would manage those patients, which medications may be more beneficial or more good for patients with diabetes during the COVID-19 pandemic. But again, the most important thing is they get vaccinated, and we try to control their blood sugar as best as we can. Thank you very much for listening. I don't know if I have time for questions. I thought I would have plenty of time for questions, but I don't think I think I took a long time.
Thank you, Dr. Ahmed, for this excellent talk. Actually, I'm not seeing any question except there is one. Yeah, there are two questions which are almost the same. It's like a clinical scenario about if a diabetic patient who got COVID-19 and they used the steroids for him. So is there a specific protocol regarding the controlling the blood sugar?
Yeah, absolutely. So the thing about steroids is what steroids do is they increase the risk of, they mostly work by increasing postprandial hyperglycemia. They cause postprandial hyperglycemia. So after eating. And so if you look at a blood sugar profile of someone with on steroids, usually what you see is if you have, let's say this is normal blood sugar. Let's say just 8, for example. And you got, this is where, it's 20 is when it's really high. So in a lot of patients, if this is a 24-hour day. So this is 8 a.m. This is when they wake up. What you will see is they will have a blood sugar that's really good, but when they wake up, and then after during the day, it starts going up a lot. Their blood sugar goes up a lot. And then overnight, it starts coming down again. So the best way to manage this kind of rise is maybe to give them some sort of insulin that you can give in the morning here. So this is what I like to do, is to give them an insulin that can work in the morning. So you give them the insulin dose here, and it matches this kind of profile where it goes up and then goes down. And so one of the best insulins, I think, would be NPH. It's an old insulin, but it's very good for patients with who are on steroids, because they get a lot of postprandial hyperglycemia. But I need to remind you of something very important. The recovery trial, which looked at using steroids in patients with COVID-19, it found that there was only a benefit in patients who are either hospitalized on oxygen or who are sick in the ICU in critical care on mechanical ventilation. So if you're talking about an ambulatory patient who's at home, they shouldn't be taking steroids for COVID-19. They could be taking steroids for other reasons, but they shouldn't be taking steroids for COVID-19. And so this is most likely not relevant because those patients who are critically ill on steroids, when their blood sugar starts going up a lot, usually they are in hospital, usually they are on insulin infusion. So I just want to remind you that please don't prescribe steroids to patients who are outpatient, because in fact, the recovery trial found that patients who did not require oxygen, dexamethasone maybe was like associated with worse outcomes. So if you give them dexamethasone, it's a little bit worse. It wasn't statistically significant, but it was tiny bit worse if they take steroids and they're not sick. It's only good for sick people, probably because those sick people in the hospital, they have a lot of inflammation. So in COVID-19, there is an initial phase where there is an infection, the infection itself, but then there is a late phase where there is significant inflammation and the cytokine storm. So if they come with mild symptoms in the initial phase, you want their immune system to fight the virus. So you don't want to give them steroids. You want the immune system to remain active to fight the virus. If you give them, but if they develop severe infections later, or not a severe infection, but a severe reaction later from a cytokine storm, this is when the immune system has overdone it now. And the immune system is out of control and is causing more damage than benefit. So this is when steroids are more beneficial. And so so please don't give steroids to patients who are ambulatory, who are at home. Only if they need oxygen in hospital or if they are critically ill. This is when steroids work best for COVID-19.
Thank you, Dr. Ahmed. And actually, you answered the next question, by the way, which was, is there any relation between the cytokine storm and diabetes? But you just mentioned it. So
yeah,
thank you,
absolutely.
Dr.
Yeah,
Ahmed.
so cytokine storm may be increased in patients with diabetes. Yeah.
Yeah.
Thank you.
Thank you, Ahmed, for your excellent talk. And I think we can move to the next presentation. Our next presentation is going to be with Dr. Thamer Al-Isa, but I don't know if Dr. Thamer is with us or. Okay, so our next speaker is going to be Dr. Thamer Al-Isa. Dr. Thamer, he's a consultant physician and head of the division of endocrinology, diabetes and metabolism at Jabir Al-Ahmed Hospital. He's a clinical staff at Dasman Diabetes Institute in Kuwait. Dr. Thamer is certified by the American Board of Internal Medicine and a fellow of the American College of Endocrinology. He's the chair of the examination committee of the Kuwaiti Board of Endocrine and Diabetes Fellowship Program by the Kuwait Institute for Medical Specialization. Welcome, Dr. Thamer.
Dr. Tamer is joining shortly in 2 minutes. He's just coming.
No worries. Dr. Thamer, I think he just joined us again.
مساء الخير.
Welcome, Dr. Thamer.
لين دكتور وسام كيف حالك؟
الله يحفظك يخليك إن شاء الله. Dr. Thamer Al-Isa, he's a consultant physician and head of the division of endocrinology, diabetes and metabolism at Jabir Al-Ahmed Hospital. He's a clinical staff at Dasman Diabetes Institute in Kuwait. Dr. Thamer is certified by the American Board of Internal Medicine and a fellow of the American College of Endocrinology. He's also the chair of the examination committee of the Kuwaiti Board of Endocrine and Diabetes Fellowship Program in the Kuwait Institute for Medical Specialization. Welcome, Dr. Thamer, and the floor is yours.
Thank you so much. Really appreciate it. Thank you, Dr. Awsan. Thank you for the Amiri Day for the kind invitation to come and join you today in this excellent meeting. Let me just start sharing my slides. Okay, so I was given the task today to talk today about COVID-19 experience with diabetes, trying to shed a light a little bit on some local experience and some local data we have from Kuwait. I have no disclosure related to this topic. So definitely we're facing a high prevalence of diabetes in Kuwait and in the Gulf region generally. So it's not a strange thing to find that there is this comorbidity or morbidity would be affected a lot by the COVID-19 situation. So, and it's actually an important comorbidity that comes in patients who present and get admitted with COVID-19. The CDC has realized that really early during the pandemic. So its announcement in March of 2020, they actually described that people with diabetes at high risk of developing complications of this disease. And they need to be aware and start to use their self-isolation and all the reducing the risk of contact for infections. One of the initial studies that came out describing this issue of diabetes and the COVID-19 was a meta-analysis of more than 46,000 patients, mainly from China, where they looked at the prevalence of comorbidities in patients who get admitted for COVID-19. And they found that diabetes is second on the list, with a prevalence of about 8%, plus or minus 6%. Now, we have to realize that the prevalence generally in China of diabetes is actually pretty low, not comparable to what we face here in the Gulf and in Kuwait in general. And this is 8%. It's very close to what the prevalence in China. They also looked at severe compared to non-severe patients and looking at the odds ratio. And they found that diabetes, even though it's increased the odds ratio about 2, but it did not reach statistical significance. So it was leaning towards developing further complication and severe patient presentation. One of the good trials that described diabetic patients with COVID-19 infection is the Curando study group of diabetes with COVID-19. It's a French study. They looked at a larger group of patients with diabetes being admitted with COVID-19 in France in about 53 locations. They enrolled about 1,317 patients hospitalized for COVID-19. It was during the first peak that France faced back in March 2020. And what they saw is that those population who are diabetics admitted to the hospital with COVID-19, vast majority of them were males. The average age was about 70. Vast majority of them were type 2 diabetics. They were overweight. They had poor control, or let's say not a target control of A1C. Almost half of them had microvascular complications, and almost 40% had macrovascular complications. Majority of them were on metformin therapy, and about a third of them were on insulin therapy. They looked at the follow-up for them as a cohort for an outcome of about 7 days, at what happened after 7 days. And they saw that patients who ended up having the primary outcome, which was death or mechanical ventilation at day 7, is almost a third of those patients. And it's characteristic that those patients were age of 70, vast majority were males, and they were overweight. There were few items that kind of independently linked to the primary outcome, which was the higher the BMI, the dyspnea on admission with the lymphocyte count that is low, and high AST and C-reactive protein. Another outcome looked at was death, and 10% of population developed death. And those patients were similarly, most of them were males. They were older, mean age was 79, and they are slightly less in BMI level. And they had the same level of A1C control of about 8%. And they were found there are some independent factors that increases the risk of death. They looked at the age, the presence of microvascular and macrovascular complications, and also obstructive sleep apnea, Also the dyspnea, lower GFR, high EST and the platelet count, and C-reactive protein. These are predictors for the death outcome. Another data came out from the Corando trial, which was more recent. And here they described a larger group of patients. Now it's almost 2,800 patients, larger locations. And in terms of the characteristic of those diabetic population, it really did not change much. They still had suboptimal control, majority men and elderly. And here they looked at the hospital discharge and death. And with larger group of patients, the prevalence of death in this outcome was larger, it's 20% here. And similarly, they found that the higher the age, the presence of microvascular complication, more insulin use, dyspnea, and some of the markers of white cell count, C-reactive proteins, and low platelets, those were the deleterious effects and increasing the risk of death. While patients who were able to get discharged was about 50% of them. Similarly, the deleterious effects were because of the similar higher age complications and some laboratory changes, including white cell count and C-reactive protein. So this is one of the good data that described the outcomes of diabetics. Now, do diabetics develop further severe episodes or further severe deterioration of their COVID-19 infection? This is a meta-analysis where I looked at about 6,400 patients from 30 trials. And what they found that diabetes in COVID-19 patients was associated with poor outcome. And this poor outcome included mortality, severe COPD, severe infection, disease progression, and even ARDS. The outcome has been influenced by the age, so the higher the age and more hypertension, that affected the outcome. Really good data from the UK. They looked at the rates of mortality in type 1 and type 2 diabetes, and they linked that to the whole population. And so it's a larger group of patients, 23,000 patients with COVID-19, and they looked at the overall death rate per 10,000 population. Patients in type 1 diabetes, here in red, they had 3 times the higher the risk in hospital death compared to non-diabetics and even the overall population. Whereas patients with type 2 diabetes here in this line has even double the risk related to the development of in-hospital death compared to patients with overall population. So here we can realize that the outcome in terms of complications are higher, even the mortality is higher, and is mainly much higher in patients with type 1 diabetes. What about Kuwait local diabetes data? So this is one of the first descriptive studies looking at the characteristics of patients who got admitted with COVID-19. This is a study that looked at the hospitalized patient in Jabr al-Ahmed Hospital in the time between 24th of February, so that's beginning of the pandemic in Kuwait, till the 7th of April. So they were looked at data from about 1,158 hospitalized patients. As you are aware, in the beginning of the pandemic, there was a large population who were not Kuwaitis. So about 47% of this group were Indians, and only about 26% were Kuwaitis. And with that, the prevalence of diabetes among the patients who were admitted was about almost 23%. And this is actually very similar to the national prevalence of diabetes in Kuwait. So even though majority were actually Indian, we still seen a large of admission in patients with diabetes, meaning that being diabetic did not really differentiate whether this is a Kuwaiti or a non-Kuwaiti. Here they looked also about the patients who were admitted to the ICU, and there were about 9% of those patients were admitted in the ICU. Out of these patients, which were in the ICU 104, about 24% of them had diabetes. So this is exactly the same as the prevalence of the whole population who were admitted to Jabr al-Ahmed Hospital. They looked here at the characteristic of diabetes, and they linked that to an outcome. And this is related to the risk of ICU being admission to the ICU. And on multivariable assessment, they showed that the odds ratio for a diabetic person to have an ICU admission was 5.5. So that's really high for the development or for this specific outcome. And they matched or they adjusted this ratio of odds ratio for the age and gender. Another paper here describing more for the 103 patients who were admitted to the ICU in the retrospective cohort. So the same population, beginning of March to the end of April in Jabir Al-Ahmed Hospital, they looked at the characteristics of these diabetic patients, of these patients who were admitted in the ICU in the 103 patients at that time. They saw that the diabetes was the most common comorbidity that these patients had, about almost 40% of them. This is followed by hypertension for about 35% of these patients. These patients with pre-existing hypertension had a risk factor for mortality odds ratio 3.2, but patients with diabetes did not have a statistically higher proportion in the development for mortality or other complications, even though it was trending towards being positive or being statistically significant, but did not reach that point. So it was almost 49% versus about 31%. Another question here, do patients with uncontrolled diabetes, when they admitted in the hospital, do they do worse or they do better or about the same compared to people who are much more controlled related to their diabetes? This is a study for about 500 patients in China. They looked in the Hubei province. They looked at the outcomes in patients who are diabetic admitted to the hospital, whether they had a good control of their diabetes or they had a poor control. And what they saw here that this is the percent survival, it was actually less. So survival of poorly controlled were actually less compared to the well-controlled patients diabetic. This is the adjusted ratio of 0.4. So significant higher risk in patients with the outcome in patients who are poorly controlled as diabetic. Similar population, they looked at other outcomes, specific outcomes, looking at ARDS, almost 15% compared to 7.2 in the patients who are controlled diabetics. More than almost triple in patient developing acute kidney injury, more than triple developing acute heart injury, and all-cause death was 5 times even more in patients poorly controlled compared to well-controlled diabetes. This is the data from Kuwait, also similar, looking at an outcome based on diabetes control. Here in this data, they looked retrospectively for about 417 patients, COVID patients, admitted to Jabir Al-Ahmed Hospital from February to May of 2020. What they looked here is the log of fasting plasma glucose and the log for ICU admission. And they wanted to see whether there is a relationship between the higher or the lower of fasting plasma glucose and the admission for ICU. They used a cutoff of about 7 millimole as a fasting plasma glucose. Anything beyond 7 will be marked here towards this side. So here we can see that any levels that is above 7 millimole, that increases significantly with the increase in the risk of developing ICU admission. Where patients with a lower fasting plasma glucose, less than 7, they have a lower risk of developing or being admitted to the ICU. So again, here, this is also local data showing with the high glucose value, especially with fasting plasma glucose, there's a higher risk of ICU admission. Another question important to mention, do patients with the newly discovered diabetes get less COVID-19 complication than patients who are known to be diabetic for a long time? So this is also a question that came up during the whole process of looking at data. So one thing important to mention here is that patient developing diabetes as the initial evidence during the COVID-19 is actually common. And we've seen that in many situations that patients, when they come into the hospital, it will be the first time that they develop and they are aware that they are diabetic. This is a meta-analysis of several trials, mainly done in China, some of them done in the US and Italy, where they looked at about almost 500 cases of a newly diagnosed diabetes with COVID-19 infection. And they saw here that the prevalence or the estimated development of this was about 14% of all these diabetic patients. So it's common that among your diabetic patients that treating in the hospital, it's very common that some of them would be new onset diabetics at that point. But also important to say is that since it's common to develop diabetes with COVID infection, what will happen to those patients, whether they had a high glucose value or low glucose value at the time of diagnosis? This is a good trial that was done in China, where they looked at data in patients who were previously not known to be diabetic. But when they came to the hospital as an admission in Wuhan, they looked at their fasting plasma glucose and they randomized them into two groups. They looked at fasting plasma glucose less than 6.1 and a fasting plasma glucose of more than 7. And they followed them to see what will happen as an outcome of these patients. So here they looked at patients with a fasting glucose more than 7, and they saw that the 28-day mortality was much higher in patients with a higher fasting glucose. So the hazard ratio is 2.3. Patients also looked at different complications as a 28 days, and also similarly, the odds ratio of developing this was much higher, 4 times fold higher in patients with a fasting glucose that is above 7. So here we learned that it's common to have diabetes with COVID-19 infection. Patients who come in without knowing that they have diabetes and they had an elevated glucose level, especially with fasting, they're more prone to develop further complications. This is another trial in China, in Wuhan, where they looked at and they compared the outcome of, especially here for mortality, comparing newly diagnosed diabetes versus patients with known diabetes versus patients who developed hyperglycemia on admission, not known to be diabetic, but developed hyperglycemia on admission. And what they found is that patients with the newly diagnosed diabetes actually did poor compared to known diabetics in terms of outcome related to the hazard of mortality. So it had higher chance of mortality compared to known diabetes. Why would be that reason? A lot of patients, when we diagnose them with diabetes, most of the time they come with the uncontrolled diabetes just because they have not been on therapy before. So nothing was controlling their diabetes throughout their disease illness. So that's maybe one of the reasons why their outcome is actually poor compared to someone who's non-diabetic on a therapy that might control somehow the hyperglycemia. This is similar to the data in Kuwait. This is the fasting plasma glucose elevation and increased hazard ratio for mortality. In Kuwait, data was looking for ICU admissions. What would be the link between the COVID-19 and diabetes outcomes? We know that with SARS-CoV-2 COVID infection, there could be a relation to beta cell dysfunction. We know there's ACE receptors on beta cells, and this could be affected by the infection itself. So it could be a direct viral destruction. And this could affect or lead the insulin secretion ability in the pancreas. Definitely, we are aware of the cytokine storm and how much that will induce insulin resistance. And by itself, it can induce endothelial dysfunction. And this is also related to the thrombosis that we see in a lot of these patients. There might be some dysregulation of glycation, like glycation end products that will increase in the system. And this could be because of the level of hyperglycemia that develops in these patients. This excess hyperglycemia with this distortion with endothelial dysfunction, there's more chance of developing platelet activation, antithrombin 3 glycolization, and this will increase the chance of thrombosis and then multi-organ damage, and maybe even further for mortality. So this is a kind of a basic understanding what could be the reason for this outcome. Does improving glycemic control in diabetic patients can reduce the COVID-19 clinical outcome? That's a very good question. We don't have a lot of data beyond for this. This is one of the new actually published data looking for patients who were treated in the hospital for their diabetes. And they wanted to see how much the survival was in these patients after controlling their diabetes in the hospital. So it was a survival probability in about 1,500 patients with COVID-19. They were trying to achieve a glucose control during their either non-ICU stay or during the ICU. And they want to look at those outcomes about 2 or 3 days after their admission, whether to the ward or to the ICU. These 4 colors, these are the lines of glucose control, where the red is actually the worst control of diabetes. This is in the non-ICU, and this is in the ICU. The level here in the red is more than 250 milligrams. That's more than 13 millimoles. So that means patients here with the glucose values that are very high, more than 13 nanomoles, they actually had a poor outcome related to the survival, whether this is in the non-ICU setting or even in the ICU. The other levels which are less than 13 nanomoles, even as well controlled in green here, there was no much difference between them. Maybe at the end here, after a month being in the hospital, maybe made a slight difference, but the initial period in a non-ICU setting, it was not much difference. In the ICU, very similar, maybe the association between the lines, but much clearer, maybe after 2 weeks, but generally there was no much difference between them. Only in patients with very poor control, more than 13 nanomoles, those are patient in red here showing the worst in terms of survival. They've been also described some prognostic markers in diabetic patients. Compared to non-diabetics, patients with diabetes had a greater inflammatory response, meaning they had higher CRP, ESR, IL-6, relative neutrophilia and lymphopenia. They were higher in diabetics. They had a higher incidence of coagulopathy with high D-dimer levels. They had more metabolic derangements, had more hyperglycemia, transaminitis. Some have even precipitated DKAs even. Severe pneumonia also they had more, especially with higher radiological scores on x-rays. What would be then a good consensus recommendation to give for these patients to improve their outcome? This is a kind of a paper that came out as a personal view of many experts related to the field of diabetes. They thought that plasma glucose control in patients who are admitted with COVID-19 should be somewhere around 4 to 8 millimoles with a target A1C of less than 7%. But this is probably something might be very hard to do in a lot of population. These are targets in patients who are using continuous glucose monitoring or the flash glucose monitoring, that they want the time in range to be more than 70% with less hypoglycemias and hyperglycemias. Another way, the ADA, the American Diabetes Association, not for COVID-19 purposes, but generally, they keep recommending that patients who are required to be admitted and to be managed as an inpatient for hyperglycemia, they need to be treated with probably therapy, mainly insulin, if the level in the hospital setting was more than 10 millimoles, especially at more than one episode. And those patients deserve to be on insulin therapy. They want to have the target control somewhere between 8 to 10 millimoles, maybe even target it to less than that, 6 to even to 8 in patients with low risk of developing hypoglycemia. The more now broad range for you for targeting glucose is now maybe more somewhere between a 6 and a 10 millimole in majority of the patients who are in the hospital. The 6 to 8, if you can control better diabetes without hypoglycemia.
Sorry, Dr. Tamer, 5 minutes. 5 minutes left.
Yeah, okay, thank you. Finishing up here. These are the two agents that we don't like them to continue on patients with diabetes, metformin and SGL2, related to renal condition and hydration. GLP-1 can be continued if it does not can cause any GI disturbance. DPP-4 and insulin, they can be continued on those patients without a risk of developing issues. Insulin can be adjusted for the dose. This is from Diabetes UK. They had a kind of scheme of what you need to do in patients who develop hyperglycemia in the hospital. You need to test every single patient when he comes in the hospital with COVID-19 for glycemic control. And also, if they present with hyperglycemia emergency, you need to treat their DKA and also a hyperosmolar state. This is a proposed protocol that was developed by a Saudi colleague and actually presented in the Endocrine Society just a few months ago, and won actually a good poster for that. They proposed the mechanism in patients who are given dexamethasone. They propose a mechanism of how to manage their diabetes. I'm going to guide you here in a short way. So a patient without history of diabetes, you want to keep them on a sliding scale insulin. If they continue to require a lot of insulin requirement or glucose more than 10, then those patients, you want to give them glargine as a basal insulin. Patient, if they do have diabetes, you want to put them back on their same insulin therapy that was on. If they don't, or they were not on insulin therapy, you want to try them on with a sliding scale for a couple of days. If their control is not optimal, then you can start them on glargine. This step is slightly questionable. We don't practice that. We like to start basal insulin immediately after admitting the patients. And here they tell you that you can taper the doses according to the meals. If patients on discharge and you're tapering off dexamethasone, what do you need to do? If those patients do not have diabetes, not on insulin therapy, did not require a lot of insulin therapy, and their A1C is actually less than 7, you can discharge them without basal insulin and without insulin. If they had poor glycemia during admission, you want to keep them on a basal bolus initially, and maybe even basal insulin at the beginning. If they're already diabetic on an insulin, give them the insulin, start tapering it off, or you even give them, if they are on oral therapy, you can give them basal insulin and also start to taper it off after a while. Last thing here, this is the COVID DIAP registry. It's an international registry globally to register patients with a new onset diabetes. We want to get more information. Jabir Al Ahmed Hospital in the Division of Endocrinology of Diabetes has been part of this global registry. We've been registering patients with a new onset diabetes to have a collaborative global work. Take home points: possible increased risk of COVID-19 in diabetics with advanced age and comorbidities, possible increased severity of COVID-19 infection and related mortality in patients with diabetes. COVID-19 could have an effect on the pathophysiology of diabetes, and blood glucose control is very important in all patients who have diabetes and any patient who gets admitted with COVID-19 infection. And with that, I end my talk. Thank you so much for your attention.
Thank you, Dr. Thamer, for your precise presentation. I can see two questions. One of them, in an admitted patient with COVID-19, the observation that the mortality related to non-diabetic hyperglycemia is higher than the mortality in already diagnosed patients with diabetes mellitus. Do we have an explanation for this phenomenon?
Okay. So probably the person who's asking the question referring to the data from China, what the graph says is that newly diagnosed diabetes do worse than known patients with diabetes. So they are already diagnosed when they came into the hospital, they had hyperglycemia, we checked their A1C that was also towards the diagnosis of diabetes. Those patients in that trial did worse. I already said the answer. It could be because those patients, when they come in, they usually have significant hyperglycemia because they never had any therapy at home before to control their glucose. And that could be different than patients who are diabetic, been on a therapy that maybe can improve his diabetes control on admission.
Okay. Another question is for patients with mild COVID-19 symptoms who are at home, do they need to stop the metformin or the SGLT2s?
It depends on what their general condition. If their appetite is good, they can hydrate very well, and they don't notice any other related respiratory symptoms, then they can continue their therapy without changes. But also they need to monitor their glucose. It might even go up higher, and they might need even to up titrate, especially if they're insulin. They need to up titrate their doses. We teach that as in the 6-day rules, especially in type 1 diabetics and type 2 who are using insulin.
Thank you very much, Dr. Thamer, and see you soon, inshallah.
Thank you, inshallah. Thank you. Have a good evening. Bye-bye.
Good evening, everybody. I'm honored to introduce Dr. Shekhar Lamdi. He completed neurology training in Christian Medical College, Chennai, South India. And he moved to Kuwait in 2000 and working as a consultant in neurology department, Amiri Hospital.
Please, there is a lot of echo in your sound.
I don't know why it is coming.
Maybe you have two devices running together.
Yeah.
Please stop the other device.
Just let me stop. Now you can hear me? Is there
Yeah,
any
now
echo?
better. Yeah.
Okay. Sorry for the interruption. Good evening, everybody. It is my honor to introduce Dr. Shekhar Lamdi. He is consultant neurologist in Amiri Hospital. He did his training in the Christian Medical College, Chennai, and in 1995. And he moved to Kuwait in 2000 and working as a consultant neurologist. And he has published many articles in the journals. And his interest in neurology is epilepsy, stroke, and neuroimmunology. So I will give over to Dr. Shekhar to present his interesting topic, COVID-19 and cerebrovascular stroke. Thank you very much, everybody.
Hello, good evening, everybody. Thank you, Dr. Gul, for your kind introduction. Can you see my slides? Hello?
No, we can't see anything. We cannot see even your video.
Cannot see my video?
No.
Now it is okay.
Your video is coming now, doctor. Just if you can share your screen.
Yeah. Now it is coming.
Yes, we can see your screen now. You can start your presentation.
But we can't see your video, Dr. Gul. We need to see your video and we need to see your slides also.
Now it is okay.
We can see your slides, but we need your video.
Actually, Mr. Mustafa video is already there of Dr. Shekhar Lambade. His video is started. We can see his video, Mr. Mustafa.
Where is the video? This one. That is okay.
No. Can you see my slides? And can you hear me? Hello?
Yeah, we can see your video and we can see your slides very well now. But there are some like you need to start the presentation mode. I mean the gallery mode.
Is it okay now?
Is it okay?
Yeah, now it's okay. Please go ahead, doctor.
No. Yeah. Sorry for this technical glitch. I am thankful to Dr. Gul for his kind introduction. I am privileged to be around with you for this wonderful webinar. I thank organizers for inviting me. Today's topic, actually this word corona or COVID, it's so popular that not only along with the virus, it is the word itself has become pandemic. And this corona has made our life miserable, that everywhere we go, we see some of the effects of that. Everything we see, it is seen through the lens of corona, whether it's a school, a hospital, or roads, or taxis, or any other crowding places. So what basically Where is the next? My outline will be like I will present some cases, 3 cases, and then some information regarding the management and mechanism. This coronavirus, there were previous epidemics also. They were called SARS and MERS. The first one started from China. The second one in the Saudi Arabia, and the camel was the culprit according to them. The beauty is that all these viruses were similar, but there are some differences. The SARS was, both these previous epidemics, they were localized in geographic area. That means they were in one area, they remained in that area, and they died in that area. So SARS was in China and Hong Kong. It started in 2002 and ended by 2004. Similarly, almost 10 years later, the MERS came. The MERS epicenter was in Saudi Arabia, and the poor camels were implicated in that. Now, what about the current virus? The current virus is similar corona. However, it is now pandemic. It has involved whole world. Again, the epicenter is from Wuhan, China. It is still ongoing with lot of mortality. And it involves many systems along with the nervous system. It enters the nervous system through nose or olfactory nerves and blood vessels or blood circulation. Basically, it docks or it attaches to the ACE2 receptors in the endothelium. So what are the things which are affected by the neurological manifestations? When the respiratory symptoms start, that is day 0, usually it is called, you can have encephalitis, myelitis, edema, Guillain-Barré syndrome, peripheral nerves, cranial nerves, Bell's palsy, cerebrovascular disease, strokes, and other para-infectious or post-infectious manifestations. The other thing is, some people before day 0, they are having underlying problems during this happy hypoxia period, but they are not manifested. This slide is very common. Previously, it was shown that this is a complex process. There are so many lines and so many terminologies here. I think they are current terminologies. In future, there may be more and more complicated type of this table. So basically what is interested for the stroke part is inflammatory markers, that is cytokines and various other interleukin 2 or interleukin 6. This is also called as a storm or cytokine storm. The other thing is vascular endothelial damage. That means the virus immediately or significantly damages the vascular endothelium. It usually causes occlusion or thrombosis. And the other part is the hyperglycemia or the underlying metabolic issues. This all leads to cerebrovascular disease, including the cerebrocardiac involvement. Now this is case number 1. This is 44-year-old male, Indian, with background history of hypertension and diabetes. This is a typical case scenario with this X-ray picture. He goes to the ICU. At his presentation, his glucose was 10.4 and hemoglobin A1C was 9.2. His renal and liver functions were normal. Coagulation parameters were normal. So around 8 days later, he develops headache and we do the CT scan. It shows atypical type of bleeding on the right occipital area. Other things I want to show is that there is subarachnoid bleed also, subarachnoid blood. And also in the third one, extreme right, you can see the parenchymal blood. So all types of bloods you can see in this condition. So further investigations for this cause, we did CT venography because of the previous CT scan pictures. It shows an empty delta sign. This is CT venography and superior sagittal sinus irregularity consistent with the thrombosis. Then follow-up CT, he had transient increase in the blood or right cerebellar hemorrhage, and which was resolving, and finally it resolved completely. We did, he had prolonged stay in the hospital or in the ICU. So many times his blood parameters were repeated, and this shows typical indicators of storm, or we do also CRP levels and D-dimer levels. So if you see these CRP levels, from day 1, it started increasing, maximum becoming at day 5, where he developed headache, and following which they persisted for some time, and slowly by day 15, the CRP levels started coming down. Similarly, we have the D-dimer, but I did not show in this graph. Regarding some other mechanisms previously described in that flow chart, that prothrombotic states or tests or markers, it is in many cases it is seen that cardiolipin antibodies, anti-beta-2 glycoproteins, microglobulin, lupus anticoagulant, they are also implicated in the thrombotic states. However, in our patient, they were all negative. This is almost around 3.5 months. There is partial recanalization of this vascular thrombosis, and currently he is doing well. The second case is relatively young. He is 54-year male, Irani gentleman, again with the background history of diabetes. He presented with vertiginous feeling and numbness of left half of body. Even though he came in the window period, he was too good, means his NI score was very low, so that's why he was not thrombolized. So he was admitted to the ward. So in the ward, what has happened is that when our blood reports came significantly altered, like his CRP, D-dimer was high, ferritin was, even though on the borderline, somehow we were not happy with this blood test. So what we did a CT scan, and first CT scan was negative. Then he developed full neurological deficits, and then now this MRI shows left pontine infarction and the right occipital lobe infarction. So it's a big lesion and multiple lesions. So we did a CT angiography, which basically shows that his basilar artery is filling defect, and his right PCA is also showing altered signals. And the left vertebral artery is also showing some filling defect. So basically he had posterior circulation stroke. The case 3 is very unfortunate case, because this is a young 15-year-old child, I will say, or adolescent. She presented with right hemiparesis and esartria for 1 day. She was feeling fatigue, and she had 1 episode of fever in the ER, and from the ER her swab was sent. She gives history that 2 weeks prior there was a transient lower limb weakness. Retrospectively, we consider that this was a sort of TIA. Her extensive workup was negative. D-dimer, CRP, storm markers, echocardiography, bubble studies, all were normal. We did have first CT scan. We are not sure because it was done outside. However, we repeated the MRI scan here, which shows significant large infarctions in the left pons and her angiography shows left vertebral and basilar thrombosis. So what is happening basically? These are typical cases which we see every day. So what are these cases? What is the importance of showing these cases? That all are young, some have diabetes, this girl doesn't have. Number one is stroke during the course of illness when he was in ICU. He had bad ARDS, he went to ICU and the COVID test was sent from there. The second one, the patient was admitted with large vessel occlusion in the ward, and from ward it was sent the test, and which came positive. And the number three is that this patient was sick and the disease was suspected in the ER. So the COVID test was sent from the ER. So COVID or this stroke and this COVID positiveness, it can happen in ICU, it can happen in the wards, it can happen including in the ER. So what are the other things which are seen in COVID infections? That is acute ischemic strokes. If you take the all occlusions like venous occlusions, DVT, pulmonary embolism, cerebral strokes, around 30 to 80% different figures are there from various studies and different parts of the world. In ICU, this ischemic events are seen in around 16 to 20%. However, figure comes to 6.4% in the general ward. Overall, the cerebral stroke is percentages or incidence is 1.6 to 2%. Even though it looks low here, when we go to the fields, the strokes are very common in our day-to-day COVID presentations and the case loads. Large vessel occlusions are much common in this subtype with or without any traditional risk factors. If you stratify the strokes, there can be large artery atherosclerosis, small artery occlusions, cardiac embolisms, undetermined origin, and some other causes. So why are these different things? This can be explained due to vasculitic injury, hypercoagulated state, microvascular thrombosis, cytokine storm, systemic hypoxia, fresh DVT. So there are different mechanisms and they present in a different types of or different ways of ischemic strokes. So now, when we look for the main cause, as far as cerebrovascular stroke or neurological presentation due to ischemic stroke, is this endotheliopathy. As I told you, the virus attaches to the endothelial receptors, ACE receptors, and it starts problem there. So what it starts, that it causes direct viral infection to the endothelial cells, collateral damage due to immune responses, infiltration, activation, complement activation, and many other inflammatory cytokines. And all these are believed to play a role in COVID-19 disease and ischemic strokes. So basically it produces a prothrombotic state, which manifests in different vessels, arteries, and veins. So this is just to show that direct viral inclusions in the endothelial cells, figure A and B. You can see the virus particles in the endothelium. And other figures, C and D, they are showing the mononuclear cells around the vessels or small vessels. So it produces vasculitis and further thrombotic processes in different organs like pulmonary or in the DVT or in the different other vessels. So what are the clinical manifestations? The microvascular lung thrombosis, venous thromboembolism, pulmonary embolism, deep vein thrombosis, then arterial events, which are like cerebrovascular strokes, acute limb ischemia, and acute myocardial injury. So most of the organs, the minor and major vessels are involved, arteries and veins are involved. So what are the markers here? Again, coming back to the previous slide, the antiphospholipid antibodies, lupus anticoagulant, they have been described in certain percentage of patients. These percentages vary from study to study, but still they are isolated cases. The proper studies are not there, prospective studies. Isolated significance that one test is positive, suppose lupus anticoagulant is positive, but we don't know what is the significance of that. But we are doing it because multiple etiologies and various vascular thrombosis and procoagulant parameters. These are the only right now we have, so we do it. Maybe in the future we will get some significance of this doing this test. Now, how to treat the strokes, especially the strokes, the enoxaparin or different heparins, antiplatelet agents, and oral anticoagulation. This is the mainstay. The mainstay, it reduces the risk of thromboembolism, the further progression. It delays the severity of COVID-19 infection and complications. It improves clinical outcomes, enoxaparin especially, due to other effects like anti-inflammatory and antiviral effect. The other thing that you already know regarding aspirin, Plavix, and oral anticoagulation. This is just showing that earlier you start, whether it is from therapeutic dose or prophylactic dose, the benefit starts from the day 1 or day 0, you start from day 1, and it reduces the further progression of the disease. Now, what are the prognostic factors? The prognostic factors are in general, but earlier the presentation, earlier the treatment, the prognosis is good. Why I am saying is that because at that time, maybe the pulmonary presentation or pulmonary involvement is less. We can very well prevent these complications by giving secondary type of treatment of COVID, like maybe steroids or to block interleukins or cytokine storm management. If you manage that part, and if you manage the other parts, the like comorbidities, diabetes, hypertension, severe respiratory symptoms, hypoxia, then possibly the prognosis is better than seeing a patient late into the illness. Intracranial hemorrhages are not common in COVID infections, but cases have been described. We don't know the reason why it is not common. Regarding the treatment of hypertension, there was initially some controversy because of the ARB, because of the receptors, ACE receptors. However, the controversy was whether by giving this medication, are you going to increase in the disease severity? But no, nowadays that controversy is not there. The current guidelines says if the patient is positive, you start ACE or you continue ACE or ARB, which patient was already taking. Same thing in the negative. If the COVID test is negative and patient is at high risk, you can start the new ACE or ARB or continue the same, what he was taking. Regarding now coming to the main topic, like what is the role of diabetes? Diabetes as such, it's discussed so many times, and previous speakers have also told in details regarding various aspects of diabetes and the metabolic problems and the risk of mortality, progression, so many things were already told. However, for me, or brain ischemia or ischemic strokes, the hyperglycemia increases the risk of acute ischemic stroke. Through what? Through multiple mechanisms. They are also called as cardioembolic disturbances. Can be isolated or it can be in the combination. Suppose somebody has a pre-existing cardiac disease, or somebody has COVID-related mechanisms like hypercoagulable state, cytokine storm, vasculitis, endothelial dysfunction, maybe cardiomyopathy, cardiac arrhythmias. All these things increases the cerebral microcirculatory failure, and which causes the brain ischemia, and that leads to the stroke. So it's a combination of two or three things. One is the basic metabolic state, other is the COVID-related issues, coagulation issues and storm, and the direct cardiac involvement, cardiomyopathy and cardiac arrhythmias. So what about diabetes? Regarding the diabetes, it is seen that the acute hyperglycemia, because of any cause, if it is present during the presentation of stroke, then the stroke severity or outcome is not good. Or sometimes it is seen that the stroke progression is much more than normal sugar levels if somebody has. So you can have two types of diabetes problems in COVID. One is new onset diabetes. This is the first time I am seeing this terminology, that there is a viral infection and there is new onset diabetes. This is directly due to the pancreatic cell damage. Then increase in the pre-existing diabetes due to severe infections and ICU admissions. There are many causes for that. So this slide just shows that this virus affects or attacks the pancreas, and which produces the new onset diabetes. And the pre-existing diabetes also affects the coagulation parameters. So both ways, the blood sugar levels are more or they are higher. And they have the therapeutic implications, because how to treat that? It is seen that in severe settings or ICU settings, you use insulin for immediate correction. Details of this therapeutics, I am not the expert for that. Diabeticians are there when to use insulin and other oral anti-diabetic drugs. There are one or two things which are, I want to say, that some promising drug like metformin, it's an old drug, but new mechanism is repeatedly coming into the publications. There are around 63,000 publications till date for this new novel coronavirus. It's very difficult to find out what is what, but what I found that there is new mechanism or new use for metformin. Both type 2 diabetes and COVID are related to increased platelet aggregation, coagulation disorders, and increases the insulin resistance. And mutually, everything contributes to the severity of the patient. This one also, this slide has been shown by previous speakers, but here I want to show that the mortality and all there is accentuation of the clinical process, what is mentioned here, that is lung injury, D-dimers, thromboembolic events. It is accelerated if the diabetes is there along with the COVID infections. That means suppose somebody doesn't have diabetes, he has this same flow chart, but with somebody who has diabetes, this gets accentuated. So there is higher chance of having all the complications. there is an interesting clinical study where it is seen that patients with type 2 diabetes mellitus taking metformin developing stroke versus type 2 diabetes, ischemic stroke, and no metformin. So what is the things we observed here? In this study, they have clearly shown that the lipid profile consisting of total cholesterol, triglycerides, LDL, VLDL, they are less or much better in the metformin group. Similarly, the STORM parameters like ferritin, CRP, LDH, D-dimer, they are also less in the metformin group, including the platelets, which are better in the metformin group. So they are showing metformin is very good according to this study. They also show that risk of acute ischemic stroke is less in the metformin group, and the neutrophil lymphocyte ratio, which manifests the inflammatory reaction, is also much better compared to the non-metformin group. So overall, they say it's very good. Regarding the mortality, in one of the Chinese study, it is seen that patients who had strokes and diabetics, 104 patients were receiving metformin and 175 did not receive metformin. So what they saw is that in-hospital mortality is significantly less, 2.9% versus 12.3%. So now this metformin is becoming a hot topic. And now if you go through this long list, there are almost 10 things they are showing which are helpful if you use the metformin. That it reduces the host binding, it increases the ACE stability, reduce the risk of viral infections, then effects on mitochondria, oxidative stress, then endosomal pH modulation, and microvascular complications. So I don't know where this metformin actions are now reported and not previously, but as it was shown only for the management of diabetes. So it has so many other metabolic effects. So now some interesting points here, that during the beginning of this epidemic, the patients were so much terrified that they reduced their visits to the hospital. So much so that around 23% of heart attack patients did not go to hospital, 20% of stroke, 10% of uncontrolled high sugar. There is sudden drop of the patients reaching to the hospital. So why it is like that? It is because of so many parameters. This is also called as a paradox. That means the number of cases are increasing in the pandemic. However, the clinical cases or number of cases we are seeing in the emergency or in the ward, they are less. So this is a paradox. The pandemic is increasing, but the cases are not increasing. Maybe some other causes. So one of some few causes are covidophobia. That is a fear due to the pandemic. So they want to stay at home. Sometimes they are advised to stay at home. Likelihood of somebody who has a disease, who has MI or stroke, recovering at home is almost nil. Then fear of hospitals. Patients do not come into the hospital. I have seen that patients are waiting outside the hospital, outside the door, that they don't want to come inside. Then some patients simply ignore. They are not careful, or they are careless, whether it is there or it is not there, it doesn't make any difference to them. So these are some new terminologies. Then the new issues which we have seen or which we never heard about. Nowadays, patients were waiting for the vaccine. So now vaccine has come. So there is a relaxation in the population. Some are happy, so they accept the vaccine. some have fear, so they reject the vaccine. Then country-wise and public response and government regulations are there regarding this issue of vaccination. Okay, but now still something more. There are viral variants, British variant, South African variant. So we don't know where are we. And now this second wave, we are still doubtful that it is affecting everywhere, but yes, it is definitely there. People are not saying openly, but it is there, whether it's in Europe or Middle East or even in my country, India, the governments are afraid to say that second wave has come or it is coming. In Germany, I read in the newspapers that third wave and fourth wave it is coming. So then regarding the other words, this telemedicine. Telemedicine is a new word which we are now practicing or we are advised to practice, which effectively reduces the patient-doctor contact and the spread of the virus. Then there is a role of social media. This role can be both positive and negative. So what is the take-home message? The take-home message is that COVID infection can cause stroke due to hypercoagulable state. The control of blood pressure during this disease can be done through ARB. There is no contraindication. Thrombolysis, mechanical thrombectomy can be given as usual what we were doing before. There is no contraindication regarding this viral infection. Then diabetes.
Dr. Shekhar, sorry to interrupt. 2 minutes remaining.
Yeah, just finish. This is the last slide. Okay. So diabetes has very important role as a comorbid condition because underlying metabolic conditions, cardiac involvements, as I said, cause cerebral circulatory failure or cerebral hypoxia. There is a new evidence of metformin in the anti-inflammatory or antiviral mechanisms. There may be some more, but I am not having more details regarding the other drugs. Okay, so we are still learning from this pandemic, and we will continue to learn about medications and underlying pathophysiology. I think I finished this, and thank you for kind and patience listening.
So thank you, Dr. Shekhar, for nice presentation. So there is one question related to the stroke. If anybody who is COVID positive and he has developed the stroke and he is in a state of window, do you thrombolize?
Yes.
Or you will just put him on antiplatelet?
No, we will thrombolize.
No contraindication.
There is no contraindication.
And the guidelines are very clear.
Yes.
Okay. Any other question? So by this, we finished Dr. Shekhar, nice presentation. Now I would like to introduce next speaker. Can you hear me, Mustafa? Hello. Hello. Yeah. Sound is coming?
Yeah, sound is clear.
Okay. Because we are using the two computers anyhow. So let me introduce the.
You can open your video, Dr. Shekhar.
Yeah, okay. Yeah, okay. So let me introduce second speaker. And I am proud to announce that Dr. Abdurrahman Al Faris is our second speaker, and he is most dynamic speaker for me as well. Dr. Al Faris was graduated from the University of Birmingham Medical School, UK in 2003, and then he pursued training in internal medicine and critical care, where he obtained the MRCP UK in 2011, and followed by a residency in internal medicine in McGill 2012 and critical care at University of Toronto in 2015. He obtained American Board of Internal Medicine and FRCPC in internal medicine and critical care in 2016 and 2017 respectively. He then pursued further training in extracorporeal life support and critical care echocardiography at University of Toronto and obtained certificate from the National Board of Echocardiography. He is currently the chair of Department of Anesthesia, Critical Care Medicine and Pain Medicine, and director of Kuwait Extracorporeal Life Support Program, Al Amiri Hospital, Ministry of Health, Kuwait. So welcome, Dr. Al Faris, and over to you to share your dynamic experience in the critical care related to the topic, our diabetic patient with COVID-19 at high risk for ICU admission and poor outcomes. Thank you.
Thank you very much, Dr. Gul. I'm just going to share my presentation here. Okay, my slides are clear?
It's very clear, doctor, very clear.
Okay, thank you very much. Thank you very much, Dr. Gul, for this kind introduction. Thank you again, Dr. Abdulnabil Attar and the organizing committee for this invitation. I just adapted the topic slightly to diabetes, COVID-19, and the intensive care unit. And I'll take you through these topics. I have no conflicts of interest to declare revolving around this topic. So the original topic was, are diabetic patients with COVID-19 at a higher risk for ICU admission and poor outcome? And thanks to Dr. Thamer Al-Isa, who's, I'm not sure who's still with us or not, have outlined almost everything that I was going to talk about. So thanks to him, the answer is yes, and that concludes my talk then. But we're not going to do that. I'm going to take you through diabetes as a risk factor for COVID-19 ICU admissions, diabetes as a prognosticator for ICU admissions, and then newly diagnosed diabetes in the ICU with COVID-19 patients, and what specific management strategies that are specific to the ICU. So is diabetes a risk factor for COVID-19 ICU admission? We've been inundated in the beginning of this pandemic with data, with observational data that reports outcomes on these patients so that we can learn. We can learn from this new disease and new and upcoming disease and know how to deal with it. So earlier data from China, and we've heard something similar, the incidence of diabetes comes second to hypertension, where with the increased severity of disease, you see more proportion of patients who are diabetics in these populations. This was confirmed in the United States, where earlier we were doubting the data from China, but similar numbers were confirmed in data from the United States in June, where diabetics formed the second or third after hypertension and obesity, and almost 25% of the patients were diabetics, with proportionally divided between invasively and mechanically ventilated or not. This was also associated or clearly associated with a higher mortality and lower discharge from hospital. In Kuwait, we have one of the studies that looked at reporting outcomes and nationality, and if there's any disparity there or not. And we've seen something similar to this earlier on today, where similar proportions to the rest of the population, 22% Kuwaitis with diabetes who were admitted with COVID-19 versus 12% in non-Kuwaitis. But is diabetes per se a risk factor for admission to the ICU or not? That was an interest to the world of critical care, because we wanted to identify which patients exactly would require to come to the ICU or not, so that we can triage. These ICU units have been developing and becoming larger and larger, And we needed to pick and choose who would really benefit from critical care or not, and who would benefit from earlier intervention or not. So looking at some data from France, dividing patients who are diabetic or not, we've seen proportions of patients admitted, again, observational data. This is non-randomized information. This is all observational data. Proportion of patients with diabetes were admitted to ICU more. They developed acute respiratory distress more, AKI, and stayed longer in the ICU. But in this study, there were no mortality difference between diabetics and non-diabetics. Diabetes per se, in that observational data, was the most independent risk factor that was associated with admission or need admission to ICU when it was adjusted for age, gender, BMI, and CRP. From the United States, a way again to get a different flavor, similar data were reproduced. You'd see patients with diabetes get admitted to ICU more, mechanical ventilated more, and they would die more, unfortunately. From Kuwait, almost identical reproduction of this data. This was recently published by a combined group between Jaber and the Desman Diabetic Institute, where they looked at the first 3 or 4 months of patients admitted to Jaber Hospital, and they found that proportion of diabetics were higher with increased severity of disease. Also in hospital complications, which are specific to the ICU, sepsis, ARDS, heart failure, cardiac injury, and kidney injury. Further data from Kuwait, just to highlight more, and this was, I think, was mentioned by Thamer as well earlier, that diabetics in the study by Salman Sabah from linking it with obesity also found that diabetes per se was independently associated in a multivariate analysis with admittance to ICU. What I want to highlight further is that more than what Thamer mentioned about this particular trial from Kuwait, is that even the acceptable range, which is maybe 5 to 7, you would see a rapid incline in the proportion of patients who were admitted to the ICU. I'm slightly surprised because a U shape here where the proportion admission to the ICU is higher because they're sicker if they're hypoglycemic. But anyway, within the acceptable normal range, the proportion goes up. You look further in the literature, there've been a myriad of meta-analyses, and this confirms that there's an increased risk of ICU admission in some of the earlier Chinese data. So is diabetes a prognosticator for COVID-19 ICU admission or not? Do the patients become worse or have worse outcomes? In the same meta-analysis I mentioned earlier, the earlier suggestion was yes, diabetics had worse outcomes and they would survive less when they were admitted to the ICU. Further meta-analyses pulled a lot of data from China, some from the United States and France, where they looked at the period from February to April, and around 16,000 patients, 11% of them are diabetics, and developing severe disease, and mortality was proportionally higher. In the UK, we've heard earlier that type 1 diabetics and type 2 diabetics are at 3 and 2% or 3 to 2 folds higher risk than the normal population or non-diabetics of dying when they acquired COVID-19. So myriad of reasons that we've heard so far, multiple reasons that are intermingled that could make the situation worse, whether it's disease specific and the severity that it develops, whether it's related to glucose control prior or during admission, complications that are related to diabetes, associated comorbidities, especially obesity and hypertension, and the type of medications that you might use. So these multiple factors might filter into the diabetic person becoming or having a worse outcomes. Out of interest to me specifically is the cytokines and the prothrombotic markers that we use, whether outside or inside the ICU, where you see in hyperglycemics, interleukin-6 were much higher than normal glycemics. Similarly with the dimers. And once you control patients with insulin and insulin infusion, you see that the interleukins from basal to week 3, they significantly come down. So normal glycemia and proper control really matters. Furthermore, when they compared in this particular study diabetics to non-diabetics or hyperglycemics to non, significant difference in survival was observed. Furthermore, when you look at CT scans and when you look at CT scoring for worsening COVID-19 findings, you would see diabetics having proportionally higher scores compared to non-diabetics. This is a large observational study from Mexico that tried to find a scoring system that could predict outcomes. And if you look, the reason why I put this is that a diabetic patient less than 40 in their cohort had a very significantly high score of 5. And that solely alone would put you in the moderate risk and would reduce your survival from 100% into down to 80 or 75%, which is a significant reduction in survival. Furthermore, the actual absolute value of range of acceptable glucose control really matters. And the higher you allow, even if it's as strict as 7 or around 7, you would see the cumulative mortality increasing significantly. So newly diagnosed diabetes in COVID-19 patient in the ICU, is this something a genuine concern in the world of critical care or not? We've seen this earlier as well from Tamer. I'm not going to dwell much on it, but the cumulative hazard ratio of mortality was much higher in newly diagnosed diabetics compared to known. We've seen a lot of case reports and case series of increased prevalence of diabetic ketoacidosis. And we actually see it practically every day. Not all the admissions that come to the ICU is because of ARDS or needing a mechanical ventilation or high oxygen amount. But I've seen a lot of patients who present solely with a diabetic ketoacidosis that is out of control and even is tighter to control or treat compared to non-COVID-19 patients. Moreover, this whole concept of undiagnosed or unrecognized diabetes in critically ill patients has been getting a hype and a buzz in the critical care world, especially when you look at further data that looks, this is Chinese data again, when they split diabetics compared to non-diabetics, and they split the diabetics into diagnosed diabetes or undiagnosed diabetes. They do actually poorly compared to diagnosed diabetics, which is an interesting topic here. A lot of the patient who presents to us with the associated hyperglycemia, they are newly diagnosed. So management, is there a specific management for hyperglycemia that is COVID specific? We heard some stuff from Tamer earlier, but I want to hone into ICU management per se. So the landmark trial, the NICE sugar trial that was published in 2009, set the cornerstone for managing diabetes and insulin therapy in critical care. And here they compared conventional glucose control of less than 10 millimoles per liter versus intensive care control or intensive glucose control between 4.5 to 6. And the outcomes was better in the conventional group. This was a multi-center randomized trial. At the same time, there was another trial that went against slightly these findings from Louvain, but that was a specific single center trial that is not really generalizable. These findings were very generalizable and moved away the world of critical care from very strict control of diabetes or from glucose control, sorry, very tight control into slightly allow it to be more conventional and less than 10. But we know that in critical care units, whether they're cardiac or not, that when the patients spend most of their time in the control range of glycemia, they do better. So in this study, they looked at whether the patient in a cardiac intensive care spent more over 50% of their time within a proper glycemic control, that they survived longer. Specifically to COVID-19, again, previous speakers mentioned something similar, but they have multiple centers that they've tried to come with different approaches and different analogs to how to manage diabetes. But in reality, it's not that different when you manage in ICU. Up to now, up to what information that we know now, there isn't really a different approach or glycemic control or what you seek in COVID-19 patients. But it revolves around the same concepts that we know, in specifically, if I want to concentrate on critical care, severe DKA and HHS, or even mild forms of hyperglycemia, where we would favor insulin infusions earlier on when it's difficult to control. So again, we heard something similar earlier. There's multiple factors that are specific to COVID-19, where it makes control of hyperglycemia maybe more difficult, whether it's related to glycemic control or interpretation of the biomarkers or other disease entities that might be present with diabetes in these patients when they present to the ICU. Specifically, inflammatory storms or cytokine storm or whatever other terminology that has been used during this pandemic. Specifically here, we look at two cases that they have reported association of procalcitonin, blood sugar control, and insulin therapy, whether a patient is known or not. And you see that with the advent of using insulin therapy and controlling the glucose appropriately, you see the inflammatory markers come down. But again, when I look at studies like this, I wonder sometimes that it's actually not the fact that you are controlling sugar by a therapy, but sometimes it's a reflection of the patients becoming better all over, where you see some of this inflammatory markers improving or getting worse. Corticosteroids, dexamethasone has been the mainstay of managing patients who are hypoxemic or requiring mechanical ventilation, dexamethasone to reduce mortality and improve outcomes. And it has been sometimes difficult to control hyperglycemia in those patients, but limiting the dose into a moderate or small dose makes the patients more manageable. So in conclusion, hyperglycemia and diabetes are important risk factors for ICU admission, whether they are COVID patients or not. Hyperglycemia and diabetes, including newly diagnosed diabetes, are highly prognostic, specifically for COVID. And management of hyperglycemia and targets should not be really different than generally critically ill patients, up to the data that we know so far. And that concludes my talk. Thank you very much.
Thank you, Dr. Alfares. If anybody has questions, you are most welcome to ask question.
Dr. Shekhar, there is already one question. You can see it in the question and answer box.
Yeah, that is for the Dr. Shekhar. We already did it.
Oh.
That is not for, that was for Dr. Shekhar. For so I know Dr. Alfares, in ICU is different than the general ward. So in type 2 diabetes, would you recommend insulin infusion and intensification of insulin in general wards, those who are coming with the COVID-19 positive and slightly hypoxic, requiring 1 to 2 liter oxygen?
You know, In situations like this, you always have to consider the setting that you work in and the ratio of nursing that you have and the availability of checking regular sugars, whether they're 1 or 2 hourly, and adjusting the infusion. So all these factors play a role here. And if you can change the setting of your ward, which I doubt, to be able to accommodate for these things, then I think the data that we've seen so far demonstrate that a bit tighter control or more stricter control in COVID might be beneficial. But in all reality, I'm not sure that this is a practical thing to do on the medical wards. And maybe it's much easier to apply in the ICU.
Is there any study on gestational diabetes and COVID-19 morbidity and mortality?
I'm not aware. I've reviewed all the recent literature that I came up with for this talk. I'm not aware of anything specific to gestational diabetes and COVID, especially when it comes to the critical care world. I'm sorry, I'm not aware of that. Maybe somebody else can address this question better than me.
If Dr. Ahmad Hashmi can answer.
And an endocrinologist, I'm sure, with
Yeah.
no more information than myself.
So, okay. Any other questions if anyone want to ask? So I think there are no more questions. So by this way, we are going to conclude the session of 8th Amiri Diabetes Conference. And thank you very much, everybody. And thank you all for us.
Thanks a lot.
Mr. Walid, are you in? Mr. Walid Husni?
Good evening.
I think Dr. Tamer, Dr. Tamer,
Yes.
I think you can start your presentation.
Okay.
Hi, this is Walid Hosni from Novartis.
Hi, Walid.
And
Sir Walid, can you open your video, please, so you can introduce Dr. Tamer?
I think maybe Walid has issues.
thank you very much for symposium. Tonight, endocrinology at the Institute. Dr. Tamer.
Walid, you're breaking up. I think you have a problem with your internet. So let me start right away. I think that's easier. Is that okay with the organizers? Is that okay?
Yes, please start, Dr. Tamer. I think you have been well introduced so many times.
Okay, so
you don't need introduction now.
No. I was talking just about an hour ago. Okay, so let me start my slides here. Okay, so I'm delighted to be the speaker here at Novartis Symposium, and really delighted with their invitation with Novartis to come and talk to you today about management of diabetes. So thank you, Novartis, for the kind invitation. So my topic today is talking about early treatment intensification in type 2 diabetic patients from the guideline perspective. So let's start with this. Okay, so it's very understandable, the natural history of type 2 diabetes, and it's well understood that there are certain pathophysiological changes that develops early on, even before the onset of hyperglycemia, or at least the detected hyperglycemia. Before this is 0 time, which is the time of diagnosis of diabetes. Before that, a patient develops significant insulin resistance, which require the beta cells to function even better to produce more insulin secretion. This is also goes hand in hand with some increase in the incretin effect, but unfortunately with the increase of insulin resistance, they will be more resistant to incretin and further production of insulin. Until we reach a level that even with increasing level of insulin and also incretin, that's not enough to maintain normal glycemia, and dysglycemia will start happening at that point. Patients tend to see some postprandial glucose elevations. A lot of them would happen at the beginning. Some patients will start noticing some fasting glucose elevations. And that would be very obvious when the time of diagnosis comes up, that whether it's a postprandial or fasting glucose, both will be elevated and diagnosed at the time of the diagnosis of diabetes. We're definitely facing a global pandemic of diabetes. This is similar to the COVID-19 pandemic. Prevalence is large among different populations in the world. Here in the Middle East and North Africa, we are expected by the next 20 to 25 years that the prevalence of diabetes could increase up to almost 100% even more. So this is definitely a big burden for management of diabetes. And with that, unfortunately, even before we reach that point, the further increase in the prevalence, we're still having, including our region and also internationally, a lot of challenging in getting patients under control. This is data from the NHANES, which is a regular census that comes up every few years, looking at different parameters of the US population health. This is looking at patients who are diabetic and not having their A1C less than 7%. It's almost 50% not getting control. This is the panorama, which was done in Europe. Similar idea, looking at who are these patients who have got their A1C control less than 7%. You can see these are multiple countries. The best countries would be around 50%. So again, we're still facing internationally a problem in getting patient under control. And we should not forget, diabetes by itself, glucose by itself, glycated hemoglobin by itself, it's a very strong predictor for developing of cardiovascular disease, whether it's stroke or acute myocardial infarction. So glycated hemoglobin, it's still the control of that becomes still a priority, even with the presence of other comorbidities or other medical conditions, including blood pressure, cholesterol, obesity, and smoking. So it's very important and crucial to control diabetes. And we definitely understand is that the more we control A1C, the more we control diabetes, then we definitely can improve some of the outcomes related to diabetes complications. This is from the UKPDS. We understand that lowering A1C of about 1% can lower the risk of developing microvascular disease by about 37%. So this is important to understand is that we need to bring HbA1c down. We need to get patients under control. We can prevent some of the complications related to diabetes, specifically microvascular complications, and specifically talking here about kidney outcomes or nephrogenic outcomes of diabetes, specifically albuminuria. So no wonder that diabetes control still comes up clearly in the guidelines. This is from the American Diabetes Association, the yearly standard of care, talking about that the greater absolute risk reduction comes from improving glycemic control, and more modest reduction comes from near normalization. So when you take care of this high glucose level, very poor control of diabetes, then you get a big drop in the risk of developing complications. Anything near the control will be having a less impact on general complications. And we need to understand is that we should not really delay the intensification of therapy, the way to monitor and treat diabetes. We should not delay it as much as we can. This is a good data from Thailand, where they looked at patients at a specific time, and they looked at how they were able, if they get their control within a specific period of time or shorter period of time, what would be that as an impact on their health generally. It's a small trial. So at the baseline, both of these groups, whether they treated well or not treated well, the baseline A1C was about 10%. At the end of the study, patients with no inertia, meaning they had to do the proper titration of therapy, they got their A1C reduction in by 3%, whereas with much delay in the control of diabetes, they were able to get their A1C reduction of about almost 1.5%. The ones who had better A1C reduction without significant delay, they had less risk of developing ophthalmic complications. And this is here related to the incidence or progression of diabetic retinopathy. You can see the difference here as an odd ratio of almost 8. So significantly, we can improve these outcomes without much delay. And also from large data in the UK, when they looked at a large population from the primary care, more than 100,000 patients, when they delay their control of 1 year beyond a time when their A1C was 7%. So if your patient is 7% and you wait longer than 1 year to control them to be less than 7%, then you have a chance of 67% higher risk of developing MI, 50% of stroke, 64% of heart failure, and 62% of the composite endpoint of all these three. So we should not really delay. Even with 1 year delay in this population, the risk of developing complication has increased significantly. So the typical kind of way of how to approach patients to treat their diabetes and get them under control is the kind of this scheme. This is a very well done graph by Del Prato, and you've probably seen multiple times in a lot of conferences, when this is a kind of a stepwise control of diabetes control. And this is a kind of conventional. So someone comes up with a diabetes control diagnosis of somewhere around 9 and 9.5% A1C. Patients are started on diet and exercise, minimally reduces A1C, not get them into target, they lose the control. You start one therapy, get them into some improvement, then you titrate that single therapy, and then you start to add 1 or 2 more therapies. So this way of conventional, more of a stepwise, is very hard to push patients into control of 7% and keep them there at 7%, because that's the ideal situation. That's different if you can actually do more of a intervention approach that's actually early and more combined. So here, this is diet and exercise and starting monotherapy relatively early without significant delay. Anytime that I don't see further drop in A1C, there where you will have to titrate and up-titrate a therapy or even add a therapy. So early combination, when you do that early, you can push patients under control relatively early within the diagnosis, and you keep them there under control as much as you can. And whenever you see someone comes up from this control, where his A1C comes up slightly more than 7%, here when you titrate the combination therapy and even add further, because you want to keep him at the goal of 7%. So there are some potential advantages of early combining therapy to control type 2 diabetes. The use of lower doses, individual ages, so you can start, instead of giving 2 therapies with maximal doses, you can actually do a combination of 2 smaller or moderate size doses in 1 pill or combined pill. More rapid achievement of glycemic control, because as we saw here in the graph, you push them more into toward control as early as possible. You target multiple core defects with complementary modes of action. We know that the diabetes therapies have different modes of action. So if you join more than one, you can actually hit the diabetes at more than one location. So this is what we mean here. This is a group of the oral therapies, not the injectables, from the sulfonylureas, the migletides, TZDs, metformin, alpha-glucosidase inhibitors, DPP4 inhibitors, and SGLT2s. The typical mechanism of physiology of type 2 diabetes, which we explained in the beginning, they do have an issue with insulin secretion, insulin resistant, and increase in the hepatic glucose production. So these are the 3 triad, the very common characteristic of type 2 diabetes. The known therapy, which can deal with these 3 triads, improving insulin, reducing resistance, and lowering hepatic glucose production, we don't have one single oral therapy to do all these together. So the combination can help each other. For example, Metformin is good improving insulin resistance and lowering hepatic glucose production, but you need something to push insulin secretion either by sulfonylurea nucleotides or even by DPP-4 inhibitors. So this is a combination where you can target more than one core defect with the type 2 diabetes and treat them as a combination therapy. The ongoing progression of the guidelines and how they're developing, how they are actually putting the evidence out in the guidelines have been changed significantly. This is from the American Diabetes Association from 2020. If you remember carefully, I'm sure that now since we're evaluating patients with diabetes, we need to either stratify them as risk for cardiovascular disease, CKD or heart failure, and these patients belong to this group, where ideally they need to be treated with SGLT2 inhibitors and GLP-1s, or you don't have those kind of complications of these patients, and then you treat them with the regular other therapies like DPP-4s, DZDs, sulfonylureas, even insulin and GLP-1 receptor agonists. So with that, from the guidelines, when you try to do early combination therapy, this can be considered in some patients at the treatment initiation to extend the time to treatment failure. And this is an important term that we want to kind of elaborate here in the next slides, is that we want to keep patients from developing failure of their treatment. Because what's happening in the conventional way, you start the therapy, very soon after that, you develop the treatment failure when you need to add a second agent. So what we want with this therapy is to push the patients into well control, stay there under good control, and avoid the failure of the therapy. Avoiding meaning avoiding getting the HbA1c even higher than the target range. So then we can stay longer during the control. This is what we mentioned about that. This is a trial that was also a very well-known trial, the ADOPT trial, where they looked at, or they had new onset diabetics, type 2 diabetics, and they randomized them to receive 3 different agents. At that time, back in the 90s, rosiglitazone was very common to be used. So the randomized patient either to rosiglitazone, metformin, or glyburide. You can see here, those are 3 arms. Patients with the glyburide has the biggest drop in A1C. And keep in mind here, those patients just diagnosed with type 2, and even their A1C was only mildly higher than normal. So only an average of about 7.3 or 7.4 A1C. So those patients with glyburide, they had the biggest drop in A1C because of the sulfonylurea action. But those patients has actually the quickest patient who failed therapy, meaning their A1C crossed the 7%, the earliest were the sulfonylureas. Other groups of patients, whether rosiglitazone or metformin, they continue to be in control of their diabetes even longer, for about a year longer or more compared to sulfonylurea group. Here you can see in green is the metformin, so a failure somewhere around 3.5 years. With rosiglitazone is even 4.5 years. So different therapies can have different outcomes in how to control the diabetes. And we have to appreciate that because we want to prevent this treatment failure. One of the good combination therapies we've been practicing for many, many years now is combining DPP-4 inhibitor with a metformin. We understood that they are complementary mechanism of action. In blue here with DPP-4s, DPP-4 can increase the intact GLP-1 receptor agonist, the GLP-1 molecule itself, and that has its own action in improving insulin secretion and reducing hepatic glucose production. DPP-4 can directly inhibit the glucose hepatic production and through the suppression of the glucagon from the alpha cells. DPP-4 also can improve some markers related to beta cell function and help to synthesize more insulin. Metformin, on the other hand, we understand that can decrease hepatic glucose production in the liver and can increase the level of GLP-1 also, and has an insulin synthesizing properties, more in the liver than in the muscle. So these kind of two fill up the spaces between each other and would have a great effect together if used both. So DPP-4 represent a common add-on treatment. It carries little or no hypoglycemia. It's weight neutral. It have a very good safety profile, including cardiovascular, similar to placebo, except for saxagliptin and alogliptin, which can increase the risk of hospitalization of heart failure. No timing or dosing issues. You can dose it anytime, especially in Ramadan. It's very, very safe and easy compliance to be taken as a once daily or even twice a day, depends on the DPP-4 inhibitor. I want to present here as a kind of putting what we discussed so far into a clinical practice. This is the VERIFY trial. It is one of the common trials, or one of the important trials that was discussed in the last 2 years. VERIFY is the glycemic durability of an early combination therapy with vidagliptin and metformin versus sequential metformin monotherapy in a newly diagnosed type 2 diabetes. It was a 5-year multi-center randomized double-blind trial. So what is the intention of this therapy? Well, of this trial, we'll talk about in the next slides. But here we want to appreciate that patients in the VERIFY trial, they enrolled patients who had very good diabetes control from the time that they were enrolled. They were newly diagnosed, but they did not have a very high level of A1C. So they had a good control from the beginning, before even a therapy had started. And if you compare them from the large cardiovascular trials or the conventional versus intensive control of diabetes, VERIFY is actually represents the more better controlled diabetics that are involved in these trials compared to the other trials which enrolled patients who had a much higher A1C control. So the design was that, as we mentioned, it's randomized double-blind, it's a 2 arms parallel group consisting of a screening visit and a 3-week run-in period. The primary was to define a failure threshold, meaning what we want to know from this trial is that if we give patients an early combination therapy, vidagliptin and metformin, versus monotherapy of metformin and then escalating whenever it's required, do this kind of 2 ways of therapy management of type 2 diabetes, which one fails sooner? Okay, not which one does better, but which one fails sooner. So this is the whole idea of the trial. So over a 5-year treatment period during this patient's treatment, it was looked at and evaluated for the failure. As we said, it's a multinational, multi-center, 34 countries are involved, 2,000 patients were involved, multiple regions, multiple countries in the regions. The age criteria was 18 to 70 years, BMI was 22 to 7, A1C, look at that, 6.5 to 7.5%. So the target here is to enroll the patients who had a good control from the beginning. And because what? Because we want to see when do they fail. Here, the ideal is not to control them, but preventing them from failure. They had a good kidney function, their recent onset diabetes, so on the last 2 years they were diagnosed. They could be drug naive, or they could be on metformin therapy in the last 4 weeks. So this is the design of the trial. So patients are enrolled and they went into a run-in period of 3 weeks. This run-in period, they were given titration of metformin, reaching to the maximal dose of 1,500 milligram daily. After reaching that goal, those patients were randomized to 2 groups. The first group, metformin plus vidagliptin, given as a 50 milligram twice daily, and metformin plus a placebo. What the primary outcome? Who fails sooner? Okay, that's basically the idea of the therapy. So we can know if a combination therapy can protect patients, keep them controlled for a longer period of time, or only a single agent will be able, similar to do that. How they define failure. So defined failure is that when patient cross the more than 7% mark, that will be indicated as a failure. And they have to do that on 2 separate visits, on 3 months and then 6 months. At 6 months, they will have a call, whether they are failure or they are not a failure. And they have to have 2 readings of A1C more than 7%. That trial even continued even further on, which we'll mention later, to look for a secondary failure, meaning those patients had some adjustment of their therapy, and now we want to see if their failure rate is actually low on a long-term follow-up after the 6 months. This is the baseline characteristics of patients, about 1,000 in each arm. About half were women. Mean age was about 54. Duration of months of their diabetes duration is about 3 months, because as we said, they are on new onset. A1C was excellent, 6.7%. Fasting glucose 6.9, BMI 31, and they had the kidney function normal, and most of them, and also current smokers were randomized well between the 2 groups. So what's the result here? So this is the first failure, or the initial treatment failure of these patients. So here the patients were randomized to, as we mentioned, metformin plus Vadegliptin in the orange, and then metformin as a monotherapy in the yellow. What we can notice here, after 6 months of therapy, what we notice is that patients on monotherapy failed more compared to patients on metformin Vadegliptin. That is actually the risk of failure increased about 50%. So that's the increase in the level of the failure rate. So 50% more in patient in the monotherapy compared to the combination therapy have failed therapy during the 6 months. This is even when it continued on, you can see that those patients continued failure and never actually were much improved. So there's always a difference between the two groups of these patients. Patients with Vadegliptin metformin, their failure rate was much lower compared to the monotherapy of about 50%. Here, this is important to mention, which is when or at what year did patients lose, or at least half of the patient have lost the control or maybe developed a treatment failure. Here in the first group here, which is the monotherapy of metformin, about 3 years, half of those patients have failed the therapy, meaning they crossed the 7%. Whereas patients in the dual combination, they only lost failure or they touched the 50% of the population only after 5 years. So this tells you that if you start patients on an early combination, you can buy 2 additional years having patient under well-controlled therapy before half of them at least reach the cutoff of more than 7%. Okay, so this is, I think, a very well way of how to look at this data is that we can keep patients under control for more longer period of time compared to monotherapy. Another thing that in the study that they looked at the secondary failure or second failure, where the patients who are failed when they are receiving the combination therapy, they're continued on the combination. But when patients failed on monotherapy, they switched them to combination. And they also looked at the failure after that part. And whoever fails that even, he will be started on an insulin therapy as a rescue therapy to improve their diabetes in general. So this is the first failure. The second failure came here, which is looking at patients whether they can keep controlling their diabetes even further on, or they lose control after titration, an improvement of their diabetes control. If they do fail that, then they would go to insulin therapy at the end, whoever failed from each arm. So this is the secondary outcome, which is, does the patient with type 2 diabetes benefit more from having combined early therapy during pharmacological treatment compared to a more sequential additive strategy? This is the time for the second failure. Now, patients on the initial failure, if they're more of monotherapy, they were added or switched to combination. So there are a lot of patients now switched to combination. And even those patients who continue to be on metformin monotherapy for a longer period of time, they had a failure of 1 year. So even when we look at patients at 1 year, patients on metformin monotherapy, they still had a higher rate of failure compared to fixed dose combination. Here, the ratio was about more than 30% higher risk that those patients with monotherapy could have a sustained failure after a year. This is, I think, important. It kind of summarizes everything here. In patients with treatment with 5 years, having a lower A1C of less than 7%, reaching that goal of less than 7% at 5 years, patients on the monotherapy, you only will have about 38% reaching that goal, which are the patients who never failed, who continued on treatment with an A1C of less than 7%. That's different from patient on a combination. More than half of them, 56%, still continued and stayed below 7%. They had a better control throughout that time. It tells us the ratio of proportion of patients who are with A1C of less than 7%, whether they're on early combination or initial monotherapy. And at each time, this is per month and this is per years, at any given time, there is always more patients hitting the goal of less than 7% in the early combination in blue, more than compared to the initial monotherapy in green. So any time during the follow-up of 5 years, there is always more patient under control with early combination. Even if you lowered your cutoff to have them controlled of less than 6.5%, the blue always wins. the early combination is always better or higher proportion of patients compared to with initial monotherapy. The overall safety, so we appreciated the effect. Now, is there any additional safety issues with this early combination versus initial monotherapy? At least one adverse event, there was no difference between the two groups. Serious side effects or adverse events, there was no difference between them. Death, there was no difference. Even hypoglycemic events, numerically there was higher levels here, but statistically it was not significant between the two groups. This is an outcome. It was looked at as a further analysis of the trial where they looked at macrovascular events. So this is an adjudicated event. So it was not part of the original trial design. So they wanted to see these cardiovascular events as a safety parameter of these patients. And what they saw is that the hazard ratio for developing macrovascular events was actually higher in patients who are on metformin monotherapy versus patients on vardagliptin combination with metformin. So this is not primary outcome, it's an analysis of an adjudicated macrovascular events. One more part of the information, this is a brand new information that was presented at the European Association Study of Diabetes, ASD conference, the virtual conference last September, where they, in the same VERIFY study, they looked at some results related to the beta cell function. And they evaluated this effect on the newly diagnosed type 2 diabetes, which are the enrolled patient in the trial, with the effect of the vardagliptin metformin early combination therapy. So what they found here, they were measuring the HOMA-B parameter, which is an estimation right here, which is an estimation of insulin sensitivity compared to comparing both the two groups, the early combination and the initial monotherapy. And what they noticed here is that with early combination, the HOMA-B parameter, which measures insulin sensitivity, was actually higher in patients with early combination compared to patients with initial monotherapy that did not gain much in the HOMA-B parameter. So this gives us a soft, not really solid evidence, but a soft evidence. There are some molecular changes happens with the early combination therapy that can maybe help beta cell function to live better. And maybe this is actually the underlying mechanism why patients stay longer under control, is that maybe because they have a better improved or a better sustained beta cell function. So the conclusion of this specific presentation was that early combination treatment with vardagliptin and metformin in patients with type 2 diagnosed diabetes, newly onset, showed improvement in the beta cell function compared to metformin monotherapy. So key findings from the VERIFY that we talked about, that early combination treatment halves the risk of time to the initial treatment failure versus monotherapy of metformin. So again, as we mentioned, you can lower the risk of developing the failure for about 50%. Median time to failure was 3 years in the initial monotherapy, whereas in the combination was 5 years until half of the population have failed the therapy. When all patients were receiving combination therapy, the risk of time to second treatment failure was reduced, as we mentioned later, in 26%, because you can keep the control even further down. Both approaches were safe and well tolerated, not noticed to increase any side effects, whether minor or serious. So with that, I end my talk, and thank you so much for your attention. I'll be delighted if we have time for any further discussion and questions.
Thank you very much, Dr. Thamer, for the interesting talk. And actually, we have 3 questions here so far. So the first one is there any study on gestational diabetes and COVID-19 morbidity and mortality?
I think this is a part of from the previous talk, I think, Walid. I think they mentioned that in the previous talk. So I think we should skip that. Let's go to the next one, I think.
Okay, the next one is if a patient with newly diagnosed diabetes and A1C of more than 10, how long we have to continue insulin before changing to oral antidiabetics?
So if you have a newly diagnosed diabetic with A1C of more than 10%, how long we have to continue insulin before changing to orals? Well, it depends what's the improvement of this patient is. So you probably started insulin this patient because his A1C is elevated. Well, the guidelines tell you if you have an A1C of more than 11, or if you have symptomatic hyperglycemia, ideally you start insulin therapy. Try to push this glucotoxicity even low, and then you can switch those patients to oral therapy. But if you have an oral therapy and then you add a basal insulin, for example, I don't think you can do the switch. But for the first explanation, if this is someone with significant hyperglycemia, very high A1C, and you start them on basal insulin or insulin generally, and you improve this glucotoxicity, so once you get to see much improved glucose response, then you can start right away the oral therapy and try to see if you can wean him, his insulin off.
Thank you very much, Dr. Thamer. The last question is, do we need to start anti-lipid medication at first diagnosis for all diabetic patients?
Definitely, you can do that. There is no contraindication to do it. So far, the guidelines about lipid management mention is that most diabetics, they need to be on statin therapy, especially if they're older than the age of 40, especially if they have other comorbidities, or if you do any kind of a calculator, risk evaluation calculator, and you see the risk is higher than a specific cutoff of pertinent to that calculator, then you definitely need to statin therapy.
Thank you. We have another question here is, how can you as a physician convince a newly diagnosed patient with type 2 diabetes to take 2 drugs instead of 1 drug?
Okay, so the ideal situation is that if, let's say, classically, you will start metformin therapy. Most of the time, you will start 2 pills of metformin, whether 2 500s, 2 750s, 2 850s, 2 1000s. So you can't actually tell the patient, I'll give you 1 tablet of metformin and another tablet of another agent. So that would be 2 therapies at the same time. Another situation is that you can do, and you have them available in the MOH in Kuwait here, is that the combination therapy. You have several combinations with metformin. You have a metformin with DPP-4. You have a metformin with the SGL2. So you can have different combinations available, and you can give those patients a pill that has 2 therapies at the same time. You can use it twice a day, for example, or once a day, and that would do the trick. So I think, discussing the patient, and this is exactly what you want to translate. So whatever we talked about, change it into a theme or a language that fits a patient, and try to translate it to that. I'm translating to you is that early combination can have patients under control for a very long time. Do your own translation of that specific information to a patient level. You can tell him that if I give you this therapy, which are 2 pills, for example, I can save you from taking additional therapy for much longer time than if I give you 1 therapy. So I think this is a kind of way of how I approach patients.
Okay. Thank you very much, Dr. Thamer. I believe there are no further questions. Thank you very much for the very interesting and informative talk, as usual. And thank you for everybody of the attendees.
Thank you so much, Wali. Thank you for the invitation. Thank you for the Amiri Day also for their.
Thank you, Dr. Thamer. Thank you very much.
Shukr, Walid.
I think we have Raneen, who's going to introduce Dr. Rashid Al-Hamdan. So, Raneen, can you start?
Sure. Good evening, everyone. Thank you very much.
Can we have your video?
Unfortunately, I have a problem with my camera. Is it a problem?
Okay. No problem. No issue.
I'm very sorry. Good evening, everyone. Thank you very much for attending our session today. Thank you, Dr. Thamer, for your informative session also. We are honored to have Dr. Rashid Al-Hamdan with us tonight to share his clinical experience with dyslipidemia management. Precisely, he will be talking about the impact of PCSK9 inhibitors on ASCVD patients. As you know, Dr. Rashid is a consultant cardiologist and team leader of internal medicine in KOC Hospital, Kuwait, in Ahmadi. Dr. Rashid, the floor is yours.
We can't see Dr. Rashid.
Dr. Rashid is joining right away.
Yes, I'm joining.
Let's just give him a few minutes, please.
Okay.
Hear you and see you, doctor.
Beautiful. Let me switch this off. Hello? No, I have to do this. Okay, can you hear me?
We can
Yes,
hear you very
doctor.
well, Dr. Rashid, but we can't see your
Beautiful.
screen.
Beautiful. Okay, let me try to share the screen.
Yeah.
Okay. Oh, what happened? What did I do? Okay. Share screen. Okay. This is okay. Share screen. Let me get my. I'll open the presentation here, and okay. Okay, so I'll do this. Okay, where is the presentation? Okay, so I don't know. Okay, here. Can you see it?
Yeah, we can see you. We can hear you very well. We can see you very well, and we can see your screen also very well, doctor.
Oh, beautiful. Okay, let me get rid of. Okay, here. Yeah. Now, just a technical issue. How can I remove the screen, my screen, that I can see me here? Okay. So how can I remove this? Okay. Yes, I saw it. Fine. Beautiful. Okay. This way you can now still you can see me. Correct?
We can see you very well, doctor.
Beautiful. Good. Okay. So how long later? Like how many minutes more? 5-10 minutes more?
You can start, doctor. You have 45 minutes.
You can start.
I can start now.
Yes, sure.
I'm sorry. I thought that. Okay. Thank you. Okay. Just a second. Let me just. I'm sorry for that. I thought it's 45. So I just. Okay. Okay. So I'll just download the. I'm just going to mute the mobile so that we don't get annoyed. Okay, during wise and. Okay. This is 1, and this is 2, and good evening, ladies and gentlemen. Thank you for joining to see this lecture about PCSK9 inhibitors and evolocumab and their effect on atherosclerotic cardiovascular disease. The title of the talk is The Impact of PCSK9 Inhibitors on Atherosclerotic Cardiovascular Disease. My name is Dr. Rashid Al-Hamdan. I'm a consultant cardiologist in Ahmadi Hospital, the KOC Ahmadi Hospital. So, without any due delay, we'll start. Now, coronary heart disease, as it is well known by the majority of you or all of you, I hope, is a leading cause of global burden of disease and death. And you can see here the data from Kuwait, obtained from WHO site, that cardiovascular disease amounts to around 41% of the total mortality in the country. And it is followed by a distant second, which is injuries, and a third, which is cancer. Both of them do not even amount to get the stratum or the effect of the cardiovascular disease on mortality. Cardiovascular disease actually per se shortens life expectancy, as we can see here in this slide from the Framingham data, that compared with healthy subjects, history of any cardiovascular disease leads to a reduction of more than 7.5 years of the life expectancy of an individual. And a history of an acute MI shortens the life expectancy of an individual by 9 years. And a history of stroke can reduce the life expectancy of an individual by up to 12 years compared to a healthy individual. And these data were obtained from the Framingham cohort study. In the Inter-Heart multiple risk factors, looking at all inhabited continents, Salim Youssef in the Lancet shows that the greatest burden, or 90% of the burdens, is attributed to acute myocardial infarction is because of the effect of lipids compared to any other risk factor for cardiovascular and coronary heart disease risks. The prevalence and incidence of coronary heart disease, looking at epidemiological data projections for the population of Earth between 2015 to 2035. You can see here that a global estimate of 17.7 million people died from cardiovascular disease in 2015. And of those, 7.4 million were due to coronary heart disease in particular. Globally, there is an estimated 20.7 million who have new coronary events annually. And there are 32 million myocardial infarctions worldwide every year. Ischemic heart disease is projected to be a leading cause of death, mortality, as well as morbidity in the world in the year 2035. Coronary heart disease is a leading driver of cardiovascular deaths worldwide. You can see here data from North America that in age standardized cardiovascular deaths per 100,000 of population, 62% is attributed to ischemic heart disease. This number is around 55% in our part of the world. It's, again, in Central Latin America, it's 60%. In Western European countries, it's 50%, followed by ischemic strokes and hemorrhagic strokes. Hospitalization or hospital readmissions and mortality are common in the year following myocardial infarction. Looking at data from hospitalized patients for MI, a number of 78,000 patients were examined and followed for up to 10 years. And we can see here in the first year following an index MI, 10.2 and 15 or 16% of the patients experience 1 or 2 coronary heart disease rehospitalization, respectively. And the incidence increased to 21% and 36% in the 10 years following the index MI. Now, trying to understand or comprehend coronary heart disease risk focuses on myocardial, with a focus on myocardial infarction. CHD, coronary heart disease, ischemic heart disease is caused by buildup of a plaque in the coronary arteries. Disrupting this plaque can lead to a cascade of full or partial obstruction of blood flow to the heart. And this can lead to death, MI, or other complications. Acute coronary syndrome is a manifestation of coronary heart disease, an acute event. Angina is just the chest pain because of the CAD or CHD. Myocardial infarction, also known as heart attack, is when a myocardial or cardiac myocyte dies because of prolonged myocardial ischemia, most likely due to stopping of the blood supply. Heart failure is a condition which is an end result of whatever you are, of the patient is having as a heart problem, usually in this time and age, coronary heart disease. The coronary heart disease is a manifestation of atherosclerosis. It starts with fatty streaks, and the fatty streaks can develop very early in life. Lipid starts to accumulate more and more. The atheroma grows, and this leads to a plaque. The plaque starts as a stable plaque, then it becomes unstable once the surface of the plaque ruptures. A ruptured plaque leads to platelet adhesions, activation, and aggregation of coagulation cascade, and that would lead to a thrombotic thrombus and thrombotic formation, leading to an obliteration of the blood flow in that particular artery. Clinical atherosclerotic cardiovascular disease is a systemic disease, progressive, affecting multivascular beds, and can lead to cardiovascular events. The myocardial infarction is ST elevation, non-ST elevation, can result in permanent damage to the cardiac myocytes or to a recoverable damage or reduction of function. And as you can see, the universal classification of myocardial infarction have classified MIs into 6 categories: type 1, 2, 3, 4, A and B, and 5. What's more important to us is types 1 and 2. Type 1, spontaneous myocardial infarction related to ischemia due to primary coronary events, such as plaque erosions. And type 2, a myocardial infarction secondary to ischemia due to either increased oxygen demand or reduced supply, coronary artery spasm, coronary embolization, anemia, arrhythmias, hypertension, etc. Now, type 3 is a sudden unexpected cardiac death, usually attributed to coronary artery disease, that happens before the spillage, of markers in the blood, manifested usually with arrhythmias or new left bundle branch block. Type 4 is related to instrumentalization. Type 4A, PCI related. Type 4B, myocardial infarction associated with stent thrombosis, usually discovered by either autopsy or post-event PCI, another look. And then type 5 is CABG related. Type 1, spontaneous MI related to ischemia due to primary coronary event, plaque erosions or rupture. 2 is the secondary to ischemia due to either increased supply or increased demand or reduced supply. Now, why is it important to have a look at these things? Risk of recurrence of MI. The risk of recurrent cardiovascular events happened with patients with prior CHD, and this is staggeringly high. A look at 46 or 47,000 patients with acute coronary syndrome with or without prior stroke, TIA, or MI. In 1 year, in post-ACS patients, the trajectory of incidence for recurrent MI was steepest during the first 3 months after the first ACS. First recurrent cardiovascular event over time by event type. You can see here cardiovascular death, MI, stroke. This is within the first year, and this is the event rate. And you can see here, the more you go, the more the events can happen. And this is a pooled data from post-ACS antithrombotic therapies of 4 clinical trials. The REACH registry, patients with previous MI and no history of stroke or TIA, you can see here at 16,000 patients with previous MI, following them up for 4 years, the cardiovascular death or myocardial infarction or stroke happening in this cohort in the first year, 5%, 8% in the second year, 12% in the third year, and 15% in the fourth year of follow-up. And these data emphasize the importance of intensive medical therapy to minimize the progression of atherosclerotic cardiovascular disease. So what treatment modalities we have currently for dyslipidemia? The most important thing that we are working with now is the LDL theory, that LDL is the evil that is causing the majority of these deleterious effects. And you can see here by pooling the data of the cardiovascular disease lipid-lowering agent trialists that a reduction of 1 millimole of LDL decreases the relative risk for coronary heart disease by 1 to 2%. Okay, so sorry, the absolute risk and the relative risk by 20 to 25%. So this is not a small thing to achieve. And the problem is that this is not being achieved easily. In the EuroAspire surveys 4 and 5, where 27 European countries participated, with patients, men and women less than 80 years, hospitalized at least 6 months and at most 3 years prior to the interview, patients elective or emergency CABG, patients with emergency or elective PCIs, acute MIs, they were interviewed and the data was collected. The proportion of coronary patients achieving the European lifestyle risk factors, therapeutic targets for cardiovascular disease prevention as defined by the ESC on cardiovascular prevention, this was the main interest of the surveys. And what they found that EuroAspire 4, EuroAspire 5, the 5 is in red, you can see that many patients are on statins. More than 85% were on statins. Many, more than 90% were on antiplatelet agents. But looking at the results, you can see here that patients who are achieving an LDL of more of being less than 1.8 were few. 71% were above an LDL level of 1.8. Remember, these patients are very high risk, so they have to be lower than this. Around more than 1/3 are more than 2.5, which is like a huge burden of disease. There was also, there were less patients achieving an LDL, they were achieving LDL less than 1.8 in EuroAspire 5 compared with 4, and this is important, but nonetheless, many were not achieving that value. Now, the lifestyle modifications that are important for us, okay, are the reduced caloric intake, fruit and vegetable diet, grains, the use of fish and lean meats as opposed to red meats and pork in these countries, excuse me, limit saturation fat to 7% of total dietary use, achieving a certain degree of physical activity, 30 minutes per day, majority of days of the week, muscle strengthening activities more than 2 days a week, and the use of pharmacotherapy. Now, pharmacotherapy, statins, fibrates, fabric acid derivatives, niacin, bile acid sequestrants, and cholesterol absorption inhibitors. These are the classical anti-LDL agents used. And this is where they act in the liver, majority of them statins, in the small intestine, ezetimibe, and then the bile acid sequestrants, again, the small intestine. Now, of those of importance, the statins which affect or stop the rate-limiting step of cholesterol synthesis, HMG-CoA reductase inhibitors, are of particular importance for us. Now, we know that statins can be given in 2 intensities, low to moderate intensity statins, and with that we can be offered for patients who have mild or low risk of atherosclerotic cardiovascular disease. And they include rosuvastatin of 5 to 10, atorva of 10 to 20, pitavastatin 1 to 4, simvastatin 10, 20, and 40. All of them are low to moderate intensity statins. High intensity statins were chosen to be based on the effects, atorvastatin 40 to 80 milligrams and rosuvastatin 20 to 40 milligrams. And these they work in the same way. However, they thought to reduce atherosclerotic cardiovascular disease more than moderate intensity. And it was shown that they can achieve a reduction of greater than 50%, depending on the baseline. Now, what are the sources of cholesterol? Dietary and biosynthesis. The biosynthesis can be affected and stopped by the HMG-CoA reductase inhibitors, the statins, and dietary by stopping the absorption like ezetimibe. Some kind of landmark trials here that worth mentioning, the 4S trials, which was the breakthrough trial in the 1994, 1990s of the last century, where they showed that patients who are taking simvastatin, the 4S trial, Scandinavian Survival Simvastatin Study, again, randomizing 4,444 patients with coronary artery disease. Most of these patients were all of these patients were statin naive, and they looked at the population where they had a cholesterol level between 212 and 309. And you can see here that the primary endpoint of a total mortality was reduced by 30% in the years after randomization in the simvastatin arm compared with placebo. And the secondary endpoints of major coronary events were reduced by 34% in the simvastatin arm compared with the placebo arm. The PROVE-IT study followed afterwards, and it looked at reducing the reducing effect of statins and claiming that pravastatin was superior to atorvastatin 80, and they wanted to achieve that goal by comparing randomizing 4,000 patients to atorvastatin 80 milligrams arm and pravastatin 40 milligrams arm. And the primary efficacy endpoint were a composite of death from any cause, MI, documented unstable angina requiring rehospitalization or revascularization. And you can see here that there was a 16% relative risk reduction in the atorvastatin arm. And that happened early. The curve divergent happened early in the study, in the early 3 to 6 months of randomization. This was followed by the TNT trial 1 year later, where 10,000 patients were randomized to either atorvastatin 80 milligrams or atorvastatin 10 milligrams and treat to a new target. And they wanted to achieve a lower target of LDL. And with that, you can see there in the outcome that there was a 22% relative risk reduction between the atorvastatin 80 milligrams and the atorvastatin 10 milligrams in the TNT trial. Next agent is ezetimibe, which is a cholesterol absorption inhibitor. It binds to Niemann-Pick-like 1C1-like protein and in the small intestine, and it stops the absorption of LDL cholesterol. When used, again, when used alone, it can reduce LDL level by 10 to 25%, especially in patients who had statin intolerance. And when used with statin, it managed to reduce the LDL level by 25 to 30%. There was a 50% decrease in LDL cholesterol with ezetimibe and statin in pooled data. Now, the most important study which studied the effect of ezetimibe was the PROVE-IT trial. They looked at patients on simvastatin versus patients on simvastatin and ezetimibe, followed up for at least 2.5 years. And this patient population was a well-medicated patient population with an LDL level of between 50 and 125 milligrams per deciliter. And you can see here that there was a 2% absolute risk reduction between the simvastatin arm versus the simvastatin and ezetimibe arm, okay, with the number needed to treat of 50. Okay, to reduce the cardiovascular death, MI, documented unstable angina requiring rehospitalization, coronary revascularization, or stroke in this well-medicated patient population. And this trial showed that non-statin lowering effects of LDL cholesterol with ezetimibe reduces cardiovascular events. It also showed that even lower is even better, achieving a mean LDL of 53 versus 70 at 1 year, and confirms that the use of ezetimibe is safe. And it affirms the LDL hypothesis. Reduce the LDL more, you get better results in terms of control of coronary artery disease and atherosclerotic cardiovascular disease. Now, there are certain needs for the treatment of our patients, and these needs are unmet yet. Many patients are unable to achieve the optimal LDL despite being religious on their medication. Many well-treated patients at recommended LDL goal continue to have cardiovascular events. Maybe we need to hit them harder to achieve lower levels yet. A decrease in cardiovascular event due to LDL reduction with statin still leaves 67% of events to occur. The risk remains elevated even in patients who achieve the goal. Up to 20% of patients experience tolerability issues with existing therapies. Familial hypercholesterolemia is common but still underdiagnosed, and it varies. The rate of patients with familial hypercholesterolemia varies with the location on Earth. There are certain areas where they have more abundance of familial hypercholesterolemia. You don't have to have homozygous familial hypercholesterolemia. It's enough to have a degree or the other of heterozygous to make the effect of the statins or the lipid-lowering agents a little bit affected and not optimal for the prevention of cardiovascular events in this patient population. The LDL guidelines goals are infrequently achieved in very high-risk patients. Looking at data from multiple researchers across the globe, you can see here that the percentage not achieving goals varies in many areas. In the Arabian Gulf, one study in the Gulf showed that 68% did not manage to achieve the target. In the US, Purcell et al., 96% did not achieve the target. Data from Spain, 85% did not reach the target. In Indonesia, same thing. You can look across the globe in Canada and Central and Lower and Southern America, and you can see here that again 70% did not achieve the goal. The residual risk persists despite statins, and the residual atherosclerotic cardiovascular risk is around 70%. There is a risk reduction in the atorvastatin arm of the ASCOT lower lipid lowering arm. You can see a reduction of 36%, but there is around 60% relative risk or residual atherosclerotic cardiovascular risk, which are still there. So we have to have an edge to reduce this malignant kind of a disease condition. Familial hypercholesterolemia is the lifelong elevation of low density lipoprotein. There are two types, heterozygous and homozygous. And according to recent Gulf familial hypercholesterolemia registry, the prevalence of familial hypercholesterolemia in the Gulf, in the adult population in the AGCC countries, is up to 1 to 230 patients. So that's a lot. And as I said, the degree of penetrance and the degree of genetic abnormality varies. So you don't have to have a full-blown picture of familial hyperlipidemia. All you need to do is to have a patient who doesn't respond well to your medications, and voila, you'll still have to deal with the complications of such a condition. Greater LDL exposure accelerates coronary heart disease risk. The more patients without familial hyperlipidemia, you can see here that when they start showing, or the cumulative event of the cumulative LDL effect in order for them to start showing cardiovascular or coronary heart disease in patients without familial hyperlipidemia can reach up to 55 years if they are, or if they have an elevated LDL level. In patients with heterozygous familial hypercholesterolemia, they start showing it in their mid-30s. Worse still, patients with homozygous familial hypercholesterolemia, they start showing it in their teens, 12 and a half, 13 years of age, they start having coronary artery disease. So there has to be something that we can do. The Dutch Lipid Clinic Network criteria for familial hyperlipidemia in adults is a nice chart, and you can see here that you add up the points according to the group, family history, clinical history of your patient, the physical examination, biochemical markers, and the DNA analysis. And a patient who has 8 points is definitely familial hypercholesterolemia, probable between 6 and 8. 3 to 5 is possible, and if less than 3, it is unlikely that this patient of yours is having familial hypercholesterolemia. 90% of familial hypercholesterolemia patients do not achieve LDL cholesterol target, despite statin therapies. And 80% did not achieve it even when you add ezetimibe to the concoction of their medications. So here comes the PCSK9 inhibitors and the PCSK9 role in lipid metabolism. Evolocumab as one of the major PCSK9 inhibitors. Now, what we know about the LDL receptor is that these receptors attached to the cell allow LDL molecules to get attached and be internalized. Then the complex of LDL as well as the receptor is taken up by lysosomes. The lysosome will degrade the LDL and spare the LDL receptor to go back, will be recycled and go back to the surface and allow it to bind more LDL again. This can happen, but there is also, as in the homeostatic effect on the homeostatic condition of our human bodies, there is something that stops the LDL receptors from being infinitely recycled, and this is the PCSK9. PCSK9, a protein binding to the LDL receptor, allowing the lysosomes, when they bind the LDL receptor complex, to break down the LDL. Once the LDL, as well as the LDL receptor. So there will be less LDL receptors available for internalization of LDL. So when we want less LDL, we don't want the receptors to be there. The body produces the PCSK9 to internalize and biodegrade the LDL receptors. It was noticed that mice with congenital absence of PCSK9, they have very low LDL levels in their blood, and the reason was the LDL receptors were never damaged, were never metabolized because of the absence of PCSK9, hence the idea. Now, evolocumab is a human monoclonal antibody against PCSK9. It binds to the PCSK9, stopping it from binding to the LDL receptor. Hence, the LDL receptor will get inside, allowing the LDL to be metabolized and the LDL receptor itself to be recycled and resurfacing back to the surface of the cells. Now, it is an injectable medication, can be used in many parts of the tummy, thigh, arms. It can be used as a single injection every other week, a total of 2 injections, or as a dose of 140 milligrams per week. That would be 240, that would be 280 milligrams, or you can take a single 3 injections of Repatha, of evolocumab, once a month. Now, the evolocumab has shown intensive LDL lowering across the broad patient population in the Perficio clinical program. The Perficio clinical program consists of many trials looking at patients in combination with statins, as evolocumab as a monotherapy, evolocumab in statin intolerance patients, in patients with heterozygous familial hyperlipidemia, patients with homozygous familial hyperlipidemia, long safety and efficacy studies and follow-up for patients who have been on the evolocumab for a few years, and it looked at the atherosclerosis and its lowering and the lowering effect of evolocumab, and it looks at secondary prevention for evolocumab and reducing the rate of coronary artery disease in patients who already have had atherosclerotic cardiovascular events happening. And again, finally, in the Ebbinghaus, they looked at the neurocognition effects of so low an LDL level. The evolocumab phase 3 trials in the well-known Mendel, Laplace, Gauss, and Rutherford trials, you can see here that patients who are receiving placebo versus patients on evolocumab, whether given as a monotherapy or in a combination with statin, whether it was given to patients who have statin intolerance in the Gauss trial or patients with familial hyperlipidemia in combination with statin, you can see that the effect of evolocumab weekly is staggeringly high. It's an immense 60% reduction across the patient population compared with Amiga's 16-20% reduction in patients who are taking statins. And in patients with homozygous familial hyperlipidemia, evolocumab is the only PCSK9 inhibitor approved for the treatment of homozygous familial hyperlipidemia, reducing the LDL cholesterol by up to 30% compared with other lipid-lowering agents. Repatha provided 32% reduction in LDL cholesterol compared to placebo. And it may provide a viable alternative to patients who LDL apheresis is the only suitable treatment. As you know, some of these patients' population have plasma apheresis as their only possible treatment of choice. Now, the relation between LDL cholesterol levels and atheroma volume was studied in many clinical trials. And the Reversal and the Asteroid trials, where they look at atorvastatin, at rosuvastatin and atorvastatin respectively, there was an average on-treatment reduction of LDL reflected with a reduction of atherosclerotic atheromas progression or even size as judged by IVUS, intravascular ultrasound studies. Now, the Galagov study looked at the effect of evolocumab on the progression of coronary heart disease in statin-treated patients. And in the Galagov, they looked at intravascular ultrasound as a reflection or as a demonstration to see if there is a relation between an achieved LDL and a reduction in atheroma burden. We know that LDL reduction with PCSK9 can reach new lows, but would that reflect in a reduction in the atheroma burden? There were no trials that explored whether LDL lowering beyond the 1.4 or the 1.8 achieved with PCSK9 can reflect on a reduction in the atheroma volume. So the GLAGOV was designed and conducted. The objective was to test the hypothesis that LDL lowering with monthly subcutaneous injection of evolocumab 420 milligrams for 78 weeks will result in a significant greater change from baseline percentage of atheroma volume, the PAV, compared with placebo in subjects taking background therapy of statins. So 78 weeks, randomized patients to double-blind, placebo-controlled, multi-center phase 3 trials with its medications. So patients were screened, and then there was 4 weeks of initial lipid stabilization period, and then patients were randomized either to receive a subcutaneous injection of placebo or an evolocumab 420 milligrams subcutaneously injected every month. And they looked at their IVUS before and after the conclusion of this study. The primary endpoint was nominal change of PAV, proportion of atheroma volume from the baseline to week 78. The secondary was nominal change in the total atheroma volume from baseline to week 78, and the proportion of patients demonstrating any reduction in PAV or proportionate atheroma volume from baseline, and proportion of patients demonstrating any reduction of total atheroma volume, and exploration of the incidence of adjudicated events. So we reduced the PAV, we reduced the TAV. Did that reflect in a reduction of the event? Myocardial infarction, cardiovascular death, all-cause mortality, cardiovascular hospitalization for unstable angina, coronary revascularization of any reason, stroke, TIAs, and hospitalization for heart failure. And they also looked at the changes of the lipid parameters. The plaque area was studied using IVUS, and they looked at leading edge to leading edge in the IVUS and calculated the atheroma burden accordingly during the pullout of the ultrasound probe. Now, you can see here that the baseline characteristics were basically the same. Around 60% of both arms were on high intensity statins. Around 40% were on moderate intensity statins. Ezetimibe was underutilized at that time, but that study was conceived before the current guidelines. So 2% were on ezetimibe. And you can see here the rest of the medications as baseline. Now, what we have found that the total cholesterol between baseline and on treatment was significantly lower in the evolocumab arm compared with the placebo arm, with a reduction of, you can see here the number of patients, and the reduction was minus 60% reduction in the total cholesterol. The LDL was 55% reduction, LPA was 8% reduction, and high sensitivity CRP was 0.4 milligram per liter reduced compared with the baseline, and that was not significant statistically. The primary endpoint, nominal change, was achieved in the evolocumab arm with a significant difference between the two groups. There was a 1% reduction in the value of the PAV, and there was also a 5 millimeter cube reduction in the total atheroma volume between the study medication arm, and the placebo. Now, secondary endpoint, the percent of patients showing regression was again more in the statin plus evolocumab compared with the placebo arm, whether it was the regressors by PAV or regressors by TAV. And achieving LDL and change in PAV in all patients showed that patients had a change in percent with a reduction of the LDL level okay? You can see here that patients with LDL less than 70 at baseline, the percent of atheroma volume kept on being reduced by the use of evolocumab on top of the statins, and the fraction showing regression was more with the evolocumab and statin arm. Now, the exploratory subgroup LDL changed from baseline in patients with cholesterol LDL less than 70 or less than 1.4. You can see here that once the study commenced, they dropped their LDL level and kept on having a low LDL level compared with the placebo. And the mean absolute change in LDL receptor and the LDL level was significantly more in the evolocumab and statin group. There was an absolute change of 56 milligram per deciliter. And the clinical and biochemical adverse events were nearly negligible in the evolocumab arm. The reason of discontinuation that happened in the evolocumab arm, majority of patients who discontinued were preference of the patient and all adverse events grouped together, 18 in the evolocumab arm. Now, the Repatha outcome trial of evolocumab and clinical outcome in patients with cardiovascular disease was a landmark trial. The Fourier study, the background of it is that despite using statin, many patients are unable to achieve a good control of the LDL that is required by their clinical status. Now, longer-term studies of evolocumab showed that there is a good reduction of LDL level of these patients. Now, the Fourier further cardiovascular outcome research with PCSK9 inhibition in subjects with elevated risk was designed to test whether patients with established cardiovascular disease who are already on optimal cardiovascular therapy, including high or moderate to high intensity statin, would benefit from a maximal LDL reduction with the addition of evolocumab. So to evaluate that clinical efficacy and safety of achieving unprecedented levels of low LDL with the use of PCSK9 inhibitor evolocumab. So there was a global randomized placebo-controlled double-blind trial, including 49 countries, 1,242 sites, and a huge number of 27,564 patients enrolled in that study. Now, patients were screened. They had to be between 40 and 80. Usually they were between 40 and 85. They had stroke, MI, or peripheral artery disease with additional risk factors, one major or two minor, optimal background lipid therapy, and then they were randomized in a 1-to-1 fashion, either evolocumab, 140 or 420, depending on the patient's preference, whether to have two injections a month or 3 injections once every month, or placebo with subcutaneous injection of a placebo medication, a placebo arm, and then they were followed for a long time, okay? A total of 2 years, okay? So basically the primary endpoint was a composite of cardiovascular death, MI, stroke, despite hospitalization, stroke, hospitalization for unstable angina or coronary vascularization. The key secondary endpoints were composite of cardiovascular death, MI, or stroke. Other secondaries were all-cause mortality. The sample size was based on the key secondary endpoints and powered to detect a 15% risk reduction at 90% power, assuming 2% per year event rate. That was the large sample size for. And efficacy analysis was hierarchical. If primary endpoints were significantly reduced, then key secondary endpoints was to be tested, followed in order by cardiovascular death, all-cause mortality, and then addition of secondary endpoints. So men or women aged 40 to 85, clinically evident coronary cardiovascular disease, at least one major additional risk factor, diabetes, smoking, MI or non-hemorrhagic stroke in the past 6 months of screening, or 2 minor, okay, history of non-MI related coronary revascularization, metabolic syndrome, LDL more than 130, or non-HDL cholesterol of more than 160, fasting LDL of more than 70, non-HDL cholesterol of more than 100, on optimizable lipid lowering therapy, and at least atorvastatin.
Like 2 minutes more, Dr. Rashid.
2 minutes more. My God. Okay, sorry. I have rushed today. Okay. Sorry for the delay. Okay. So basically looking at the evolocumab outcome, you can see here that this is the rate of myocardial infarction between the two populations. And you can see that this is a high-risk group of patients. Now, there was a 60% mean reduction of an absolute risk reduction of 56 milligram per deciliter between the placebo and the evolocumab arm. And the primary endpoint with the composite of cardiovascular death, MI, and stroke and hospitalization was reduced significantly between the placebo and the evolocumab arm, with hazard rate about 15% relative risk reduction. That was significant statistically. Key secondary endpoint was, again, a significant relative risk reduction of 20%. And we can see here that the efficacy and in key subgroups, that the evolocumab arm was much better than the placebo arm in regions, age, across races, and with the initial, with whatever disease they had, whether MI, stroke, or peripheral artery disease. The landmark analysis of primary endpoint shows that in the Fourier, the long duration of treatment on follow-up suggests larger risk reduction the more the patient goes on the medication. This is the risk reduction in 12% in 1 year and 19% risk reduction as the study approaches the five years. So the more the patient is taken away from the effect of LDL, the more the benefit they will have from these medications, namely the evolocumab and as well as on the standard therapy. There was a 19% relative risk reduction in fatal and non-fatal MI or stroke between the placebo arm and evolocumab, and 33% relative risk reduction in the first year, and then a 33% relative risk reduction in the third year between the placebo arm and the evolocumab arm. So what we can conclude here is that the more you reduce the LDL and the longer you keep this patient off that high effect or deleterious effect of LDL, the better the outcome of your patient is going to be. I'll just run quickly through the Osler study, which was an open label study entailing patients who were randomized to receive evolocumab in earlier phase 2 trials of the medication. And they elected to do a first phase after 1 year of being on evolocumab, and then after 4 years extra on evolocumab. So patients were randomized to take evolocumab or standard medications, and then afterwards, patients who were on evolocumab were consented, and they were kept on an open label and followed up for 2 to 5 years. And the idea was to look at the effect and the safety margin of using these agents over a long period of time, as well as on whether they can affect the patient, 1, 2, whether they still can reduce or cause a reduction in the LDL, i.e. whether there is any kind of antibodies produced by the patient against the evolocumab, rendering it useless after a few years of tolerance. And you can see here, I'll just go quickly through the methods, and you can see here that patients Once they are on evolocumab and you drop their level of LDL, you keep them on evolocumab early. This is the arm of, for example, patients who were on evolocumab early and then received evolocumab and they continued on it. You can see they kept on being low. While patients who were on evolocumab early and then randomized to standard of care and kept on standard of care, they regained or they lost the benefit of the LDL that they've lost, and they remained high. The same as patients who did not receive evolocumab altogether. So, and this is across all lipid parameters. And in fact, when you look at the long-term efficacy of Osler, you can see it the same. Patients in the prolonged or in the extended study design, patients who are on evolocumab
Your video is freeze, Dr. Rashid.
of my study, of my presentation. So thank you.
Dr. Rashid, we have one question here, if you would like to answer.
Please.
Do you think that coronary calcification score will be the part of the risk stratification?
Well, I'm not quite sure, but I think with the new advocated use of CT coronary angio, I think yes, there are multiple scenarios where a patient who has coronary artery disease risk profile and you don't know what to do with them, whether you consider them as a low risk patient or an intermediate risk patient, then and coronary risk score will play a role in stratifying these patients. The use and the availability of coronary risk of coronary calcium now makes it readily available in many locations. And remember, the guidelines, when you put guidelines regarding the use of stratification system or a scoring system for risk profile, you have to take into account the population and the availability of the whatever test modality you have. So the availability now of CT calcium scoring and the vast knowledge we are accumulating about it, I think in a short, yes, it will be. How is it going to be introduced in a complicated score like the score system for the ESC? I don't know. Maybe they will incorporate it if it can be calculated mathematically into the Framingham or the ATP profile, but in the ESC, I'm not quite sure how they will incorporate it, but I'm sure that they are working on it. And I think that there are many coronary artery disease scenarios where the effect or the number of calcium score will make the difference or break the tie, if you will, between the choice of what kind of clinical modality you have to offer to your particular patient. Thank you. Yes.
I think we are done. Dr. Rashid, thank you very much for your lovely presentation and very informative. I think Rahim would like to say something.
Yes, I just want to thank you very much for your time and effort. Thank you, everyone.
Thank you.
And thank you, Dr. Rashid.
Thank you. It's been a pleasure. Thank you, Allah Hafiz.
Okay, I would like to thank all our respected speakers for their contribution today and our participants for attending the day 2 of the 8th Amiri Diabetes Virtual Conference. We hope to see you all tomorrow again for the day 3 of the conference at 5 p.m. sharp Kuwait time. So here we conclude the day 2. And once again, thank you very much.
Thank you. Thank you. Have a good night.